Hello and good evening to all of you. I hope all of you are doing fine. Well, active participants, I can see only two names. I have Shweta and Maria. Rest are all listeners. Okay. So, uh, mm, may I know, have you given the exam before, Maria and Shweta? Or is it the first time?
Hello, Dr. Shabana. Maria here.
Yes,
How are you?
I'm good. Thank you.
Yeah. Yeah, I just told you I cleared my exam in July 2024. So this is my first time for part three. I'm totally new, I
Yes.
can say.
Yes. All right. Okay. And what about Shweta? I think you people are new. All of you are new in this batch. And I have many listeners who also cleared the exam recently, but they prefer to join as listeners. Okay. All right. So, teaching module actually, it is a very vast module, no doubt. You have to cover a lot of things. So, we are going to discuss the important topics today. But for other topics, like you have to cover the syllabus. So there are my audio records and the PDFs I have shared, like they are compilation of all the important records. So when you are going through the answer template or reading the PDF, okay, read it once, that's fine. But for part three, you have to talk and you have to speak. So I always say, talk the topic, speak the topic, okay? And you all should have a good study partner so that you can communicate really well. And like there has to be someone who has to listen to you attentively and at the same time give an honest feedback. And you people have to keep yourself motivated. At times you will feel it's very difficult. It is easier than the part two. At the same time, it is not very easy. It is not just like a piece of cake. You have to do your hard work. So it needs hard work and smart work. So, and teaching the domains tested are mainly three domains. One will be your communication with colleague, applied clinical knowledge, patient safety. So, communication with colleague is, of course, talking to your junior who is right in front of you. So, there has to be good eye to eye contact when you will go in the cubicle and you will see that it is a simulated colleague task. So, just smile and greet your junior with a hello. And you have to rule out bullying. You will ask, how are you doing today? How is everything in the department? And if he's sounding happy and he's having good eye to eye contact, he or she, it means that there is no bullying, nothing. But if the junior is looking down, there is no face to contact, and the body language is also sitting very awkwardly, not interested in whatever you are teaching, then you have to ask, may I know, do you have any concern? I can see that you're feeling very uncomfortable, and whatever you're going to disclose me will be confidential. Only then he or she will open up. And you will be tested throughout the station in your communication with the colleague or communication with the role player in simulated patient task. Then comes your applied clinical knowledge and patient safety. So that it is like how you are teaching the procedure or like any like even if there are stations where you have to teach the breech delivery. So the maneuvers, how you are teaching the maneuvers and everything that will be tested. And if any mannequin is given there, the doll and pelvis, use the props. Feel free to use the props, just like you were teaching in your department to your junior colleagues. In episiotomy stations, if there is a needle holder, hold it and show it to your junior. Do you know what it is? It is a needle holder. And episiotomy scissors is given, so it has got an angle. It is different from the normal scissors. Just explain a little bit, okay? And so also, you have to involve your junior in teaching stations. You're going to say, am I clear so far? Would you like me to repeat anything? And also ask your junior to repeat the informations given to him or her. That, can you repeat this? Okay, so, and yes, you have to ask for the feedback. That I would also love to have feedback from you regarding my session. How was it? How did it go? And how can I improve myself? So these things are there. And as we will do the stations, you will understand. And also, if you will keep listening to the audio records, you will understand how we are doing the teaching stations. All right. So, all right, active members. If we have only 2, then you people will be doing all the stations. I have texted everyone, but only you 2 have joined. Maybe others are busy in duties or what, I don't know. Rest.
No, Anita will join, but later on.
Okay. Okay, good.
Yes.
All right. Yes. Fine. So it's going to be a short session, not a very lengthy one, 6 stations, so not very, very long session. All right. Actually, there was one candidate, she withdrew in the end, so 1 seat is still empty. No problem. And please feel free, we are like colleagues. Feel free with each other, with me, with with all others who are there listening to the session also. If you have any query, please feel free to ask, feel free to type, okay? All right. Now, who will start first? The topics are known to all of you. The only thing is that now you have to come forward and speak, and we are going to interact with each other. Of course, I will be the junior colleague. I will be your role player. Okay, anyone? Shweta, Maria? I have only 2 of you right now.
Yes, I can do, but I'm afraid I'll be able to do or not.
We are all afraid. No worries.
Yes,
This is Shweta speaking, right?
yes, yes,
Okay.
I can do.
Okay. No, uh, please feel free. Please feel free. Be calm. No worries. No worries. These are the
Yeah,
practice.
my problem is that I know the stations, I know the thing, but when I speak, I just cannot complete whole and
It
like
happens.
maybe
Sometimes
lack of practice or
lack of practice. Yes. Sometimes it happens that you don't know what you should talk next, right?
yes,
It is like
yes,
that.
yes.
You become big, you become zero, vacuum.
This
We have
happened.
been through that phase, my dear. That is why we always say talk and talk and talk. When you will talk, what happens? The informations get registered in your mind. So when you start talking, it comes automatically. How do we remember so many songs? Do we mug up the songs? No, we listen to
No,
the
by
song.
listening. Yeah, listening
And then
only.
the same thing is here. Only thing is that you have very short time, so you have to talk a lot. Every station, do at least 3 times. If you still are hesitant, repeat. Do 4 times, 5 times, 6 times. That's okay. That's absolutely fine. You are your best judge. You know, like whether you need more practice or only talking doing a station 3 times is enough, or whether I should practice 2, 3 times more. So you are
Yes,
your best judge. Yes.
yes,
Some are picking up fast, some are picking up little late. That's okay. We are all different.
yes.
Right. Okay, Shweta, good.
I'll start.
Yes, you will start. No worries at all. Take your time. 2 minutes will be your preparation time. We will be doing like the way you have to do in the exam. Otherwise, it will be of no benefit. And 10 minutes will be your performance time.
So, yeah, timer will be set, na? You'll
Yes,
tell us.
I have the timer. If you also want to
Mhm.
set your own timer,
No,
please.
no, that would be difficult for me
That would be
because I'll be
difficult.
reading the,
Yes,
yeah.
yes. I have the timer in my mobile actually. So I'm just
Mhm.
setting the timer and I'll show you the station. Okay. Take it easy, very easy, please. We are all colleagues. Okay. No one is junior, no one is senior. All of us are colleagues. Okay. You have 6 slides. This is the first slide, okay? Just because this is
Yes.
the first session, I'm just guiding you, then this will be the second, and then you have to explain the graphs. That's all. Fine.
So
Okay,
previous one, first one.
first one.
Yes.
I'm starting your timer now.
Okay. Yeah, next page. Can I see next slide?
Yes, yes,
Next.
yes,
Yes, previous one.
yes.
Yeah. Can I start?
Sure. If you are ready, start, please.
Hello, I am Sweta, one of the ST5, and you are?
Yes, I'm Rina Thompson.
Nice to meet you, Reena. How are you doing?
Yeah, I'm good. Nice to meet you too.
Yeah. So how is everything in the department, Reena?
Yeah, everything is very fine.
Yeah, good to know that. So, Reena, I understand that you are here because you want to learn about the Eurodynamics. So, is it so?
Yes.
Yeah, very good, Reena. This is very important topic. We should all know that. So, Reena, may I know what do you already know about the Eurodynamics?
Well, I find this topic very difficult. In fact, that day I attended a urogynecology clinic, and there was this patient, they were doing the urodynamics. There were so many graphs, so I don't know much about it. I just know a little bit about the cystometry, and that's all. But I cannot read the graphs at all.
Mhm. Don't worry, Rita. Actually, we all are in learning phase. We learn by doing things, okay? So we learn by our seniors, by reading the materials and going through it, okay? So what we do today. So, Rina, may I know exactly what you want to learn today? What exact topic? Like you told
Yes.
me that you wanted to learn about the graph and the process and
Yes. I have few graphs also, and so I want to
mhm.
know about the urodynamics and what are the normal phases of cystometry. And I have this cystometric graph also. I don't know about these catheters and all. I get very confused.
Yes.
And I have so many graphs I have brought, so I would like to read them with you.
Mhm. Don't worry, Rina. We'll go through that. Okay. So once we learn the basic, then these graphs would be easier for us. Okay. So what we would do today that I'll go through the Eurodynamics, what is Eurodynamics, how it is done, and how the graphs are interpreted. And at the last, I'll give you the reading material about it and website address to go through, like RCOG and Strategy site. And then at any time, if you feel like I'm going fast, then you can stop me, okay?
Yes.
Okay, so now come to the Eurodynamics. So what is Eurodynamics? Eurodynamics is actually the measurement of study of functioning and dysfunctioning of lower urinary tract, okay?
Yes.
So it is done to see that how is lower urinary tract like bladder, urethra, all are working. So Eurodynamics has actually three parts like uroflowmetry and cystometry and urethral pressure profile. And when these are the simple urodynamics. So are you with me?
Yes.
So I'll explain about all the phases and parameters. So regarding the urodynamics, there are some indications like we cannot do in all patients. So
Hmm.
indications for urodynamics are like whenever there is a urge incontinence, that and treatment is failed with simple medicines. Okay, in that case, we'll go for that. And also when mixed incontinence and urge predominance, we can see in that case also, and also stress urinary incontinence where the surgery has failed, and also when stress incontinence is associated with apical prolapse and anterior wall prolapse. In these cases, the urodynamics would be advised. Uh, and contraindication for this is that there should not be any urinary infection, okay? And in pure stress incontinence, we will not go for urodynamics. And Reena, so can you tell me about one indication, what I told you?
Yes, you told me when there is mixed incontinence and we are not able to make the diagnosis and
Yes,
like apical prolapse and all.
yes, very good, very good. It seems that you are a very good learner, Reena. Okay, so now going ahead, before doing the urodynamics, we have to be sure that informed consent has been taken. Patient dignity should always be respected, okay? And infections should always be ruled out. And after that, we take the proper history to rule out all the contraindication. Proper history, examination, investigations, like I told you that urine test should be done, and bladder diary should also be maintained.
Yes.
And before, hello?
Yes.
Are you following me?
Yes, yes, yes. You told we have to take the history and everything. Yes.
Yes. Yes, to find out the suitable person. And also, then after that, we go for the uroflowmetry. First part is uroflowmetry. And also one thing we have to keep in mind that whenever a patient is on any medicine, we have to record that and we have to document in our paper, okay? So in her case note that she is taking this medicine. And after that, we do the uroflowmetry. Uroflowmetry is actually the patient is asked to void on a rotatory disc and the urine volume per unit time is measured. So this is called the uroflowmetry. Here, are you following me?
Yes. Okay.
So this urine voided volume per unit minute is per unit second, like a milliliter per second is recorded, and this the voided volume is reflected in on a screen like a smooth bell-shaped graph. Okay, so by seeing the smooth graph, we say that it is a normal curve.
Yes.
Patient is normal. So then we'll go ahead. After that, the uroflowmetry comes to the cystometry. Cystometry has two parts, like filling phase and voiding phase. So cystometry, it says that like we measure the pressure inside the bladder. We measure the abdominal pressure, vesical pressure, and detrusor pressure is measured by subtracting abdominal pressure minus the vesical pressure. So by how do we measure the pressure? So we put catheter, one catheter inside the bladder, one catheter inside the rectum, or we can place in vagina, and one feeling, two catheter would be in bladder, one feeling and one for measuring the pressure. Are you with me, Reena?
Yes. Yes. Okay. Very
Okay.
clear.
In that way, we measure the pressure and slowly we instill the saline into that and we measure the pressure, and that pressure would be reflected on the graph on the screen. Like, see, you are seeing this in the graph.
Okay.
The pressure is there, like first
Yes.
one is vesical and this abdominal and detrusor.
Yes.
Yeah. So what happens normally that during the feeling phase, there is not any contractions in the bladder, so that urine is stored. Okay. So
Yes.
if there is any contraction, that shows that there is abnormal contraction is there. During the feeling phase, there should not be any contractions. Okay. So that's why it is not showing pressure. Detrusor pressure is normal. Okay. There is not any elevation in the graph.
Okay.
So after that we measure, and patient, during the meantime, patient is asked to cough also, do exercise, walk also, so that we see that there is not any leak on exercise or cough. Okay, this will tell us about the stress incontinence.
Right.
So yes.
Yes, I have
Yes.
these graphs. So how to read? Can you tell me?
Yes, yes. So coming to this graph, there is you can see that there are different color of graph. Like
Yes.
one is filling, first part is filling and second part is voiding. And it first says about the how bladder behaves during the filling and how bladder behaves during the voiding phase. And
Yes.
also there are different pressures. Like you see,
Yes.
the purple one, the upper one is P vesical, the middle one is P abdominal, and last one is P detrusor. So all the pressures, see, you can see that the small transient upward stroke is there. This is not the pressure, but this is the like on cuff, like normal
Yeah.
when patient cuffs that, yeah, this is the transient increase in pressure. Okay. And the voiding phase, there are all leak and detrusor pressure is increased. Okay.
Yes.
So
So,
this is the normal curve, normal
right. So this
graph.
is the normal graph. Fine.
Yes.
Okay. And I have one more. What about this one?
Yeah. Yeah, see, this is the like first one is EMG that shows about the muscle pressure, blood, and how muscle is contracting. And then second one is abdominal. There is, you can see that there is not much rise in the pressure. And then second is vesicle. Vesicle pressure is high, and then detrusor pressure is high too. So when both are high, I told you that it is the detrusor overactivity. Are
Oh,
you with me?
yes, yes. So this is detrusor
So
activity,
yes.
right?
Yeah.
And how to read this one?
Yes. Can you tell me that which one is which graph, like upper one and middle one?
Yes, yes. This is the vesical pressure. There is some
Yes,
rise.
very good. Very
And
good.
abdominal pressure,
Yes, yes.
I think no
Very
rise.
good. It seems that you are very yeah, quick learner. You understand that all the pressure. Okay. So
Yes,
now this one actually, yeah, this says that vesical pressure is high and detrusor pressure is high, and there are some abdominal pressure is and there is a leak with the there is leak with the detrusor pressure. Whenever detrusor pressure is high, there is leak. Means there is urgency incontinence. Over
yes,
Okay, you can
yes.
overactive bladder with wet
Incontinence.
overactive bladder, we can say.
Fine.
Okay.
Last
Now
one.
regarding this graph, there is a vesical. First one is vesical pressure, abdominal pressure, and detrusor. Here we can see that vesical pressure and abdominal pressure is high, and there is a leak also. So this is a stress urinary incontinence. Are you following me?
Yes, got it.
So these
Okay.
are the simple graphs we know about. Okay.
Time is up, my
In
dear. Close the station. Okay.
Okay. So now I am. So how is the session, Reena?
Yeah, very nice session. In fact, I'm very like my concept has become very clear and the session was very good.
Okay, so nice to know that. So I'll give you the written material about that. TOG article is there, and also the RCOG and strategy website link is there. You go through that, and whenever we'll be doing next time, you can come to us. We'll do it together. Okay?
Thank you. All right. Okay.
Okay.
Thank
Thanks.
you. Very well done. Well done.
Okay.
There
Thank
is
you.
flow when you are speaking, and it shows that you have been practicing and you're doing the hard work. Very
No,
good.
but I think that I forget while speaking.
You cannot say
I,
everything. You know, the role player
no,
will guide you because, okay, yes,
yes, yes.
yes,
Because I cannot remember whole thing. At least 60% I can remember. That 50.
yes, that's more than enough. To pass this exam, you need 62%. See,
It was borderline actually. Last time, yeah, I got stuck at borderline. That's why I'm worried.
it's okay. You will clear, hopefully. No problem at all, my dear.
I'll practice. I'll practice.
The thing
And
is,
with your guidance, yeah.
uh, there is what you say, there is a flow when you're talking, and you have to follow the role player, your junior. So if the junior stops you and say, can you tell me about the graph? So yes, now you have to tell about the graph because there is marks if you will talk about the graphs. All right, so there is marks now there. Junior is happy the way you have explained everything, so that's okay. If he is not happy, he will keep asking you, I did not understand cystometry. What is this? What is that? If he's happy, he will take you forward. Okay, can you tell me this? Can you tell me that? All right. So same thing happens in simulated patient task. If the patient is happy, she will ask you some questions, some concerns. When you are answering the concerns, you are getting the marks if you're answering them correctly. So we always say follow their agenda, not your agenda. Of course, you will complete your sentence, 1 or 2 sentences, then answer their queries. Communication with colleague, me, it was absolutely fine. Absolutely fine. I was very happy the way you were talking. Okay, and applied clinical knowledge is absolutely fine, perfect. Patient safety, just few points we will discuss. I will tell you where. Little bit. We will discuss that. No worries. Okay, so of course you cannot explain everything about the urodynamics. You have to keep it short. All right, so you were Shweta, right? So, all right, hello, I'm Shweta. Are you Reena? Nice to meet you. How are you doing today? I understand if it is written she is preparing for a MAS-UG Part 3 exam, you can ask, I understand you're preparing for a MAS-UG Part 3 exam. Am I right? How's your preparation going on? And how about your colleagues? How's everything in the department? She will be very happy. I'm enjoying being in the department and everybody is so cooperative. Bullying ruled. You have ruled out the bullying and you have developed a nice rapport with your junior. So I understand that you want to know about simple urodynamics. Am I right? Do you have any idea about it? Have you read about it before? All right. So may I know exactly what do you want to know about it? So she will tell you this. I want to know about this. So, okay, what I'm going to do now, if she doesn't tell you that what she wants to know exactly, you can go back. Usually they will say, this will be your agenda then. Then what I'm going to do that I will be explaining to you about the urodynamics and its indication, how it is done. I will also explain the normal cystometry and I will explain to you about the graphs. Fine. Okay. All right. And is there anything else you want to know? All right. At the end of session, I will also give you the important articles on urodynamics like strategy materials and the TOG articles. Is that okay? And I would love to have feedback from you also at the end of the session. So you can ask about the feedback in the beginning itself. This is also the communication with your colleague. Then when you're explaining the urodynamics, then comes your applied clinical knowledge and patient safety points. So what is this? Urodynamics, these are combination of tests. They are done in outpatient setting to assess the ability of bladder and urethra to store and void urine, and they help to assess the function of lower urinary tract. So you explained it very well that they help to assess the function of lower urinary tract. All right, what does it include? Uroflowmetry and cystometry. So usually we don't do ambulatory or video urodynamics routinely. Okay, so what are the indications? We do in patients with lower urinary tract symptoms. So to keep it short, you can come here that we do it in patients in whom conservative treatments have failed and before surgery for urinary incontinence if there is clinical suspicion of detrusor overactivity, they had like previous continence or prolapse surgery, or there is symptoms suggestive of voiding dysfunction. Now, what we have to remember, so in urgent continence, we do urodynamics before surgical treatment. But in stress incontinence, it is not recommended if pure stress incontinence has been diagnosed based on history and examination, unless there is a suggestion of voiding dysfunction or anterior compartment prolapse or previous surgical management. So you told this, anterior compartment or apical prolapse. Now, before urodynamics, what we have to do, we have to take the history, examination, and investigation. This is important so that we are aware of the symptoms, what is the severity of symptoms, and which symptom is more bothersome, whether the symptoms are affecting the quality of life, if patient is on medication, like whether if she's taking any diuretics and all, so we have to note that. Any surgical history, then we can examine the patient with the permission in the presence of chaperone just to assess for pelvic organ prolapse, pelvic mass, etc. Even one or two, enough. And then we are going to do some investigations like urine analysis and bladder diary. And then we have to do the uroflowmetry. So uroflowmetry, this is the very basic test. Here there is a diagram and I will explain on that. So this helps to screen for voiding difficulties. Here it is a very simple test, okay? Patient is asked to void by relaxing while sitting on a commode over a uroflowmeter. And what does it measure? So if you have a graph in the exam, just have a look at the graph and say that mainly it measures the voided volume, okay? And also the post-void residual volume. Then it measures the maximum flow rate. This is the Qmax. And the pattern of flow is bell-shaped. So can you see this is the bell-shaped pattern, and it means that it is a normal flow. You can see there will be a rapid upstroke. Then there will be a curve with a continuous flow, and clear, this will be the maximum flow rate. and then there will be a quick decline which will end. Okay, so can you tell me the normal shape of the Euroflow meter? Bell-shaped. All right, you're a fast learner. Then we have the cystometry. So here there are two phases, filling and voiding cystometry. Now, what is the idea here? That the idea is to reproduce the micturition cycle. All right. And in this, what we have to record, we will be recording take help from the picture if it is given in the exam. We have to record the vesical pressure, abdominal pressure, and detrusor pressure. There are three catheters, so I will show you. This is the filling catheter. This is the first catheter, and we fill the bladder with the saline. Okay, then you have the second catheter. This is also inserted in the bladder. It measures the vesical pressure. Then we have the third catheter. Either we can insert it in the vagina or in the rectum, and this helps to this will give the abdominal pressure. And then we measure the detrusor pressure. So detrusor pressure is equal to vesical pressure minus abdominal pressure. Okay, so we will be subtracting the abdominal pressure from the vesical pressure because vesical pressure will be high. So we will subtract abdominal pressure from vesical pressure. This is the detrusor pressure. And initially, if you get time in the exam and junior wants to ask something, so what should be done initially? So initially, we have to measure the resting pressure, that is the resting vesical and abdominal pressure, okay? And then, the bladder is continuously filled with normal saline at room temperature. We have to ask the patient to record the first sensation of filling, first desire to void, and any strong desire to void. Even if you will explain simply all the catheters and how we measure the detrusor pressure, that's absolutely fine. So during the filling phase, we will ask the patient to cough, stand, jump in order to provoke the bladder, and there has to be actually no detrusor contraction in the filling phase, okay? And any detrusor contraction and leakage is noted. So no leak or detrusor contraction in the filling phase. And at the end of the test, women is asked to void to check for the pressure flow analysis. Now, these are the cystometry normal values. Not required for your part 3. It is too much to remember, but just have an idea, okay? So just remember, in the filling phase, the detrusor rise should not be more than 15 centimeter of water. So if the rise is more than 15 centimeter of water, then that is really detrusor contraction. Voiding phase also, it should not be more than 70 centimeter of water. All right. Now, pre-procedure checks are the patient safety, my dear. Okay, so what we have to do, that we have to check the patient's name and identifier also. We have to check that all the equipment is working well, and calibration should be at 0. Tell these 3 points, you will pass in patient safety. Patient's name and identifier, equipment should be working well, calibrations should be at 0 for accurate measurement. And when are we going to do the ambulatory or video urodynamics? Well, we are not doing it routinely. We will do it if the diagnosis is still unclear with the simple urodynamics and your cystometry. The question asked in the exam was, what are urodynamic artifacts? So these are inaccurate measurements which can lead to a failure of reproduction of symptom, and they can give false negative or false positive findings. Okay, then another question asked by the junior was contraindications to urodynamics. So there are only relative contraindications. One is that if patient is not able to comply with the instructions or communicate sensations, because we have to ask her to tell about the strong desire to void, and also she has to understand the instruction and she has to communicate about the sensations. If we are not able to catheterize the bladder, if she's taking some medications for bladder dysfunction, they can be stopped 48 hours before testing. If there is already an indwelling catheter, patient has some comorbidities like autonomic dysreflexia, like any neurological condition. Now, how to read and interpret. So we know about the some simple sentences I've just written, how we will see the detrusor overactivity. There is only overactivity, there is no leak. So of course there will be rise in detrusor pressure and vesical pressure. Okay, but no rise in abdominal and no leak. So incontinence, urge incontinence will be same like this, rise in detrusor pressure and vesical pressure with leak. And stress incontinence, when diagnosed on urodynamics, then we are going to say it is urodynamic stress incontinence. So rise in abdominal pressure, vesical pressure with leak. So now when we are reading the graph, first we will confirm the name and date of birth and NHS number of the patient. Calibration should be at 0. And then there are 2 phases, filling phase and voiding phase. So the way Shweta has explained the graphs, absolutely fine, 100% correct. So rise in vesicular pressure, no rise. Abdominal pressure, no rise. Detrusor pressure, no rise in the filling phase. So this part is normal. What is happening in the voiding phase? So voiding phase, of course, there will be the rise in detrusor pressure up to 70 centimeters of water. So, and then this is the normal uroflowmetry. Okay, so this is a normal graph. Coming to the second one. So yes, again, confirm the name, date of birth, NHS number of the patient. We have to check the calibration. So this is 0, 0, everything is 0. And then see the rise, abdominal pressure, any rise? No. This is only the filling phase, okay? Vesicular pressure, yes, there is a rise here. There is some rise here as well. Detrusor pressure, there is rise. Rise is more than 15 centimeter of water. This is the detrusor overactivity. All right, but there is no leak. Any leak is mentioned? No. EMG is, yes, electromyogram, the muscle activity. Fine. Third graph, so again, we have to confirm the name, date of birth, NHS number of the patient. Calibration should be at 0. Filling phase, vesicular pressure, there is rise here and here. All right. Abdominal pressure, no rise. Detrusor pressure, there is rise. So there is detrusor overactivity plus. Can we see the leak anywhere? There is leak here. There is leak here. Urge leak. So this one will be the urge incontinence. What about this one? Name, date of birth, NHS number. Okay, calibration. Suppose this is 0, 0, 0. Vesicular pressure, there is rise. Okay, so there is rise and there is a leak. Abdominal pressure, there is rise and there is, yes, so with cuff reflex and everything, there is rise and there is leak. Detrusor pressure, there is no rise. So this one is urodynamic stress incontinence. I think graph is clear for everyone. There can be 1 or 2 graphs the junior can ask in the exam. All right. So this one, just we will read like this. This is A, B, C, D. So A, what is happening here? There is cuff and there is rise. So this phase, the normal bladder response, okay? This is the abdominal pressure, so there is rise with the cuff. What about the bladder pressure? There is rise, okay? And what about the detrusor pressure? There is no rise here. So this one is the normal bladder response. Nothing is happening here, no leak, nothing. Detrusor, what is happening here? Abdominal pressure, there is no rise. Bladder pressure, there is rise. Detrusor, there is rise, but and leak is there, okay? Leak visualized. So this one will be your urge incontinence. Detrusor overactivity plus leak, urge incontinence. All right, what is happening here? Abdominal pressure, there is rise with the cuff. Bladder pressure, there is rise with the cuff. So, and there is leak, there is leak. So this one is your urodynamic stress incontinence. Got it? And this is the normal voiding flow, uroflowmetry. So bell-shaped, no problem over here. Fine. Likewise, here, can anyone try? We will read it like this, vertically. Everything is mentioned here. I just want someone to open the mic and speak. That's all. If Shweta wants to talk, and again, yes, anyone. Come on, come please.
Dr. Shabana, Maria here.
Yes.
What do you want to ask about it? Do I
Yes.
just tell about this and what is the difference between them?
Yes. How? Like what do you think is happening here?
Yeah, in case of the stress incontinence, there occurs the increased abdominal pressure as well as there occurs the vesical pressure raised, while there will be the detrusor pressure in the resting phase. There will be the leak will be the positive. That's why it is a stress incontinence, urodynamic stress incontinence. While in case of urge incontinence, there will be the rising of the vesical as well as detrusor pressure, while there will be rising of the abdominal pressure, and there may or may not be the leak.
Exactly. Right. So when there is no leak, this is just detrusor overactivity. And when there is leak, it is urge incontinence. Fine.
Yes.
Here, everyone.
Detrusor overactivity and dry detrusor overactivity. Is it so?
Yes. So
right.
With leak, it is urge incontinence or wet detrusor. What you say? Wet?
I said wet detrusor overactivity.
Okay. And other one you said dry. So there is no
dry
incontinence.
Yeah.
Fine. Okay. All right. And then you are going to close this station, ask for the feedback. If you didn't ask for the feedback in the beginning, don't repeat anything because already the marking will be there. So you can just say, how was the session? How did it go? If you have any concerns or queries, feel free and let me know. And we can arrange another session and discuss urodynamics again. I will give you some more drafts. You can read them and important articles. All right. So have a nice day. Thank you. And you will be smiling and at ease in the teaching station. Okay, well done, all of you. Thank you, Shweta. Thank you. All right. Next.
Thank you.
Okay, good. Well done. Maria.
Yeah, okay. I'm ready.
Fine, good. Take it easy.
It's quite difficult for me because I'm really just going to present first time anything. Anyway, I will try my level best.
Yes. Just one slide, take you 2 minutes.
Okay, all right.
Yeah, you want to start?
Yes.
Good. Start, please.
Hello, I'm Maria. Hi, Sarah. How are you doing?
I'm good. Thank you.
Nice to meet you. How's going everything?
Yeah, everything is fine.
Yeah, I hope you are happy being in the department.
Yes, I'm very happy. Yeah.
Okay, Sarah, I understand. You want me to sign USAID form. Am I right?
Yes. Actually, I have some concerns with my OSAT. Can you sign the formative OSAT for me?
Yeah, sure. Yes. So you want to sign me, formative USAID. Yes, okay. Any other concern?
Well, after formative, can you sign my summative also? Because, I don't have any summative OSATs. And, like my colleagues, some have got 2 summative OSATs signed, and I still don't have any summative OSAT signed.
I really appreciate that how much you are concerned about your said farm. Well, you just talked about earlier regarding the farmer to said farm. So I can sign for you this form while submit. You know that. Just can you tell me? Do you have any idea about those said? What do you mean by it, formative and summative said?
Oh, yes, yes. Formative is like when you will give some feedback, right? So I have done this episiotomy, you can see and give the feedback. And
Yes.
summative, like you can see that I'm competent. So, I have done this episiotomy very nicely. So if you think, can you just sign my summative also?
So, Sarah, do you think you are competent enough? You can stitch episiotomy independently. Do you think you are such a competent enough now?
Mm, maybe I will stitch. You can see this episiotomy. I think I have done it really very nicely.
How many episiotomies have you been stitched so far?
Maybe 5 or 6.
Okay, all right. Sarah, you told me absolutely right regarding the formative set as well as the summative set, that the formative is just a feedback whenever you do procedure, and we just check that where you have made mistake, we just rectify it, right? While about the summative, summative is like that once you are competent enough regarding this procedure, you can do independently that procedure, then you are able to sign it by consultant. And Samit who said, I'm not supposed to sign it because that I'm a senior ST5 registrar, while it can be signed by the consultant, right? So for me to say, yes, I'm going to sign it, but as you have performed the procedure episiotomy in front of me, so I would like to discuss that what you have done good and what could have been done better. So do we go for it? Do we discuss about the episiotomy regarding, your format who said, do we talk regarding it?
All right. Okay. Yes.
Okay. Sarah, when you were stitching the episiotomy, no doubt you have given proper incision. Your technique of incision was absolutely right.
Yes.
While you were also using the right material, you used the Vicryl 20 Rapid, right? The thing you missed, that was the apex. You didn't secure the apex, and it is very, very important. So whenever we just stitch the episiotomy, it is very important that we need to secure it. Otherwise, it can bleed, patient can bleed heavily, and it can cause the hematoma, right? And that can be a life-threatening for the patient. So, Sarah, I would like to suggest you that you have still need to observe more and more episiotomies so that you become a confident enough and you can perform independently. Okay, Sarah?
All right. So, but I tried my best. I don't know how I missed the apex.
Yeah, you did this a little bit mistake, but no problem. Sarah, can you tell me that how we stitch the episiotomy? How many layers are there? Do you have any idea?
3 layers, isn't it? So,
Yeah, yeah.
mm-hmm.
So what about the mucosa? How we repair it?
Yes, I think we take the vaginal mucosa, then muscles, and then skin, isn't it?
Yes, we do. You are absolutely right, Sarah. We just first stitch the vaginal mucosa, then we come to the muscles and then the skin. Can you tell me which technique we use for the mucosa?
I did continuous.
Yeah, continuous locking sutures. And for muscle?
Same continuous sutures.
Yeah, and for skin?
Subcuticular.
Very nice. So, Sarah, you have got enough knowledge regarding that how to repair it, and you are also able to repair it. But you did a very small, minute mistake, which I'm sure that when you will observe more and more cases, you are going to rectify that mistake, right, Sarah? Sarah, this is a learning phase. we need to improve ourselves. And, we usually learn from our mistakes. We make mistakes, we learn from it. And in this way, we can be a safe doctor, okay? And we can be a competent doctor. So I will suggest you that you observe more and more episiotomies in labor room, right? And once you feel that you are competent enough, then you will get a chance under supervision, and the day will come you will repair the episiotomy independently too, right, Sarah? So Sarah, I'm going to sign your formative sets, and I will definitely give the remarks that where you did, mistake, and what you have done a good things. I have to mention all of these things. Okay, Sarah? And for summative sets, once you will be competent enough, then we have to sign it by the consultant. Okay?
All right, so you can give the feedback here, like what went well in my formative OSAT.
As I told you, that your incision technique was absolutely right. You used right scissor, you used episiotomy scissor. That was also a good thing. And also other thing which I observed, that your technique was repairing the mucosa, muscle, and the skin. Everything was absolutely perfect. You were repairing the mucosa and the muscle with the continuous locking sutures, and the skin in continuous subcuticular, right? And the thing you missed, and also even you use the right thread, white thread rapid 20, but what you missed the apex of the episiotomy, right? So this was the only problem, but it is not a minute problem. It is a very important thing. I just told you, if you are going to miss it, then definitely patient will start to have a hematoma, and that can be a life-threatening for the patient. All right, Sarah?
Yes, yes. So you will not be signing my summative OSAT?
Sarah, the question is not just the signing of the paper. Here's the thing, that you need to improve yourself. Why don't you understand this point? You need to understand this point. We have to improve ourselves. If first of all, nobody's going to sign without assessing you. But in case if you are going to get it signed, still you are doing wrong with yourself. So I will suggest you, first you understand about the method and you learn. And once you are really competent enough, then you will definitely get it signed. Right, Sarah?
Okay, yes, yes. And how many formative OSATs should I get signed?
Sarah, there is no limit of formative sets. You can go for more and more. Okay, once you are competent enough, then you just decide for the summative sets. Okay.
All right. And what about summative OSATs? How many?
Summative. Yes, I told you that summative sets will be signed by 3 consultants. So there are the need of 3, summative sets.
All right, fine, okay. All right.
Any other you want to ask from me?
No, thank you. Okay.
Okay, no problem, Sarah. I will also call you when I will be in labor room, when I will repair the episiotomy. So first you observe it, and I'm sure that soon you will do under the supervision, and finally you will do independently, competently, right? Still, wherever you are doing, making the mistakes, so just learn from it, okay? So the day will come, you will be like us, expert enough on these all procedures. Okay, Sarah?
Yes, okay. And you can give me some articles on episiotomy.
Yeah, Sarah, sure. I'm also going to give you some important articles as well as links of the RCOGs and the strategy. These links are really going to help you a lot, and I'm sure you will learn more about episiotomy.
Thank you. Okay. Well done.
Thank you.
All right. Well done.
It was very difficult for me in the way I just.
It was very good. Actually, the role player, the junior, was very irritating in the exam. And she was just asking, can you sign the summative? After explanation, again, she was asking, she was showing the summative OSAT. Can you sign it? Can you sign it? So she was interrupting. There was interruption in the rhythm also. When you were if you're explaining something to someone and that person is always interrupting you, so the flow is broken, isn't it? So the candidate, they just forgot what to say next because she was very irritating role play. She was instructed to behave like that. One correction I have to make. Actually, it is in my recording and also like committee was sat. Yes, 3 will be signed, and even ST5 you can also sign if you have been signed off for that procedure, and at least 1 has to be signed by the consultant. I know
Okay.
even in my recording or somewhere, even in the answer template, I have written 3 consultants. So it is 3 summatives can be signed by the senior. Even ST5 can sign if they have been signed off. At least 1 they prefer to be signed by the consultant, and 3 from 3 different clinicians. That is the idea. Okay.
Yeah, Dr. Shabana, but I just gone to your, this station that there was written that ST5 was saying to ST1 that I'm not in position to sign it because it will be signed by the consultant. That's why I just,
I know.
I didn't.
Yes, because I revised and then I asked my friends working in NHS. So last week also I had discussion with them and they said no. If ST5 has been signed off, then yes, you can sign. If ST5 has not been signed off, then yes, he will say I cannot sign off myself because I have also not been signed off. But if they have been signed off, yes. So they are in the position to sign off. Most of the ST5s, of course, they will be signed off in the episiotomy. ST5 is a high level there. ST3, ST2, ST1, ST2, ST1 is also doing the episiotomy. So I will also share that matrix is there, the new training matrix. So I will share that. Everything will be very clear. Okay, well, and otherwise, so
Next time I will be more prepared, inshallah.
good start. Very good start. Very nice. Communication with colleague, absolutely fine. So one communication with colleague is myself, Sarah Williams, right in front of you. Others are when you're saying that summative OSAT will be signed by the consultant or by seniors. So they are your other colleagues. Patient safety, yes, Apex, she missed the Apex. You're not going to sign the summative OSAT. You will only sign and the OSAT which she has given first, formative. So, and also she's not competent enough, you're not going to sign the summative. Applied clinical knowledge was absolutely fine. You have to talk about the different types of OSATs, how you're going to give episiotomy, how it is repaired, and little bit you can talk about the principles of knot tying. That I can see you have tied the knot correctly. So are you aware of the principles of knot tying? So you can just say 2 to 3 lines. That's all. Good. And give the reading materials on episiotomy. Well done otherwise. Okay. So she will come with the 2 forms. Formative OSAT, you will see this is the supervised learning event, SLE. And summative OSAT, it will be the assessment of performance. And in the end, she will show you the feedback. So what went well, what could have gone better, and learning plans. So yes, there is no time to write in the exam. You can just scribble something. So I will write here what went well and just scribble. That's all. Okay. All right. So this was Maria's station, right? Hello, I'm Maria. Hi, Sarah. How are you? Nice to meet you. How's everything going on? And how's everything in the department? Hope you're happy being with us. Yes, I'm okay. I'm fine. Okay, that's good to know. I understand you want me to sign the OSAT form. Am I right? She will tell you all the story. OSAT has been signed and this and that. I don't understand your concern, Sarah. And may I know which OSAT would you like me to sign? Can you sign the format OSAT? All right. I will see how you have done the episiotomy and then I will sign it. Suddenly she will tell you, can you sign my summative OSAT as well? Well, I can see how much concerned you're regarding your OSATs and I appreciate that. So I would like to know, do you have any idea about the OSATs? All right, so there are 2 OSAT forms. One is the formative in which we give the feedback. We see the procedure which you have done, like here you have done the episiotomy. So I can give the feedback on that on your formative OSAT. Other is the summative OSAT. Here we see whether you are competent enough to do the procedure or not. Am I clear so far? So Sarah, initially you asked me to sign the formative OSAT. So I can sign the formative for you because we have to decide from the very beginning which OSAT you want me to sign for you. Okay. I would be really very happy to sign the summative OSAT for you. But we have decided upon signing formative OSAT. So let's discuss that first. And I'm also not, now here you cannot say that I'm not in the position. So regarding the summative OSAT, at least 3 summative OSATs should be signed. If you are competent enough, I can sign one, then some other senior can sign it for you, and you should get it signed from at least one consultant. Okay, am I clear so far? Any questions? All right, so as I told you, summative OSAT has to be signed by the consultant. At least one should be signed by the consultant. And it is signed only after you do 3 procedures independently and correctly, and it is signed only after you have been deemed competent. And it means that you are competent enough to do the procedure independently and you have the expertise in that. It is very important for us to learn the procedure in a perfect manner so that we can do safe practice and we become safe clinician. Am I clear so far? Any questions? All right, so she will interrupt you. So you're not going to sign my summative OSAT. Well, it is not just signing a piece of paper. It is about how competently and confidently you're doing a procedure. In fact, we all have learned in that way. And we do mistakes and learn from them and rectify them. And that is for our own benefit so that we can learn the procedure and skill in the correct way. And once you do the procedure correctly, the consultant can sign off the summative. So as of now, I can sign the formative OSAT. I would like to see that how did you repair the episiotomy? What went well? What you missed? Is that okay? All right. So now let's come to the episiotomy. So I can see that you have given the episiotomy incision correctly. That's very good. You have tied the knot correctly. The knot is firm and not loose. So well done. You are going to appreciate her as well for the good things she has done. Now, but I can see you have missed the apex. Now, it is very important to tie the apex, otherwise there is increased risk of bleeding, and if it is not recognized on time, there can be severe bleeding leading to formation of hematoma, and that can be life-threatening. Am I clear so far? So, I can show you how to tie the apex. Do you have idea how we tie the apex? Yes, we have to take a bite, 0.5 to 1 centimeter above the apex. All right. Coming to the knots, you have tied the knots very correctly. May I know, do you have idea about the principle of knot tying? So just you can see a few lines. The knot should be firm, not loose. It should be as small as possible, and it should only include the layers you're trying to approximate. And we need to avoid the excessive tension. Otherwise, this can damage the structures being ligated or can even snap the material. All right, and do you know how we repair the episiotomy? All right, yes, we repair it in 3 layers. And the suture material used, Vicryl Rapid 20, yes, so you have done the repair correctly and also you have used the correct suture material. Very good. So how we repair? First, we have to identify the apex, place the suture 0.5 to 1 centimeter above the apex, then prepare the vaginal mucosa, and then vaginal muscle and perineal bodies. So these are with continuous non-locking suture. There they are doing the non-locking. They don't lock, just continuous non-locking. And vaginal muscle also continuous non-locking sutures. Perineal skin, continuous subcuticular absorbable suture. All right, any questions? All right, now coming to the formative OSAT, then you can start giving the feedback. So here I will give feedback. So you will just go to the form which she has brought. What about the feedback? What went well? All right, so technique of giving episiotomy was correct and you used the correct suture material. What could have gone better? Suture of episiotomy apex needs improvement in practice because you missed the apex. What about the learning plan? So more formative OSATs and like practice episiotomy repair to get competent and ready for summative OSAT for sign off. So try to get as many formative OSATs signed off for your episiotomy. That's okay. Is that okay? So I'll be signing here and you can sign. Fine. Then in the end, if you have time, then these are all about the communication with your colleague, if you have the time. So again, if she will insist, so you cannot sign even a single summative. So I'm sorry to say, Sarah, at the moment, I can sign only a formative OSAT, okay? Because I really want you to be a competent and safe doctor. And whenever I'm in the labor room, if I'm about to repair an episiotomy, I can call you and you can observe it. Will that be okay? As a colleague, I would like to advise you that you observe more episiotomies. Then you can do it under supervision, and then you can do independently without any help. This is because any procedure must be done confidently, competently, and safely. And only once you are deemed competent, your summative OSAT can be signed. Am I making sense? Any questions? All right, so I will be signing only your formative OSAT. Be very clear in the exam. These formative OSATs will give you the opportunity to practice and get feedback for a given procedure. Try to take as many formative OSATs as you need, and then you can request for a summative OSAT. Okay, any questions? Thank you. Have a nice day. And I will also give you the reading materials on episiotomy. All right, that's all. Formative OSAT, we know she has to take as many as she can. Summative OSAT, at least 3. Okay, well done. Otherwise, good. Anything in this? No. So who will do next? Who has joined? Someone joined recently. Anyone else has joined or not? We have all listeners actually. Okay.
Hello,
Yes, hello. Who is talking?
Tushana. I am Dr. Busha. Actually, I joined from my son account.
Right. Got it. Okay. Okay, Bushra. Take the next station.
What is the next station?
This one. Okay. Take your 2 minutes. You have 2 slides. And take it easy.
Hello.
Yes, but there's one more slide. Okay, this one.
Okay.
You want to start? Okay, time is up. Start, please.
Okay. Hello, I am Bushra and SD5. I am talking to Diana Green. How are
Yes.
you?
Yes, I'm Diana. I'm good. Thank you.
Okay, Diana, I understand you joined the unit recently. And how is the going on training?
Yes, the training is going on nicely.
And how you find everyone in the department?
Yeah, everyone is very cooperative.
Okay, and it means you are enjoying with us.
Oh, yes.
Okay, Diana, I understand you want to learn about bridging thromboprophylaxis.
Yes.
Okay, can I ask what is the concern behind, especially you want to learn about bridging thromboprophylaxis?
Oh, yes. I have a patient in the ward and I'm looking after that patient along with my senior. So I have a unit protocol, and like my senior asked me, how should I apply this bridging prophylaxis in this patient? She's on warfarin and she has mechanical heart wall and she has a lot of complications. But I really don't know how to read this. I find it so complicated. So can you help me to read it?
Yes, definitely. Diana, we are here to learn together. And I will explain to you what is actually bridging thromboprophylaxis. And then we learn how to apply in the patient. It's okay?
Yes, that's okay.
Okay. First of all, what do you know about bridging thrombophylaxis? Have you had any idea?
What I know that if patient is on some like oral therapy, then we have to change it to some injectable short-acting therapies like anticoagulant, isn't it?
Yes, excellent, Diana. You are absolutely right. I mean, bridging thromboprophylaxis means any patient who is on long-acting oral thromboprophylaxis, and we have to plan for the surgery or any major procedure. We have to change it to the short-acting short-acting thromboprophylaxis that is injectable. And this is reason and importance behind of bridging thromboprophylaxis, because the patient that is taking oral thromboprophylaxis mean patient is at risk of thrombosis. Like in our case, patient has a mechanical heart wall. So if we abruptly close the thromboprophylaxis, there's a risk of clot formation. So to avoid, and if we will not stop the this oral long acting, mean there is a risk of bleeding during the surgery. So we have to switch on from long acting oral to short acting injectable thromboprophylaxis. Am I
Exactly.
okay? Till now you have any question?
No, no, it is very clear. So there has to be balance between bleeding and clotting.
Clot. Yes, exactly. So next thing is, and the if we start on the injectable, and the importance of injectable thermoprophylaxis is it is short acting, and there is the antidote. If we start enoxaparin, antidote is available, and if the risk of bleeding, we can give antidote to reverse the effect of thermoprophylaxis. Am I clear?
Yes, yes.
So we have to categorize the patient according to low risk, intermediate risk, high risk, and very high risk patient. So then we can decide the patient will take the prophylactic dose or therapeutical dose of the injectable thromboprophylaxis. It is clear for you?
All right, yes.
Here we have, as in this case, patient is admitted for hysterectomy for endometrial cancer, but she has mechanical heart wall, and we have to keep in mind the renal. This patient also having the end stage renal disease, and weight is 100. So, and creatinine clearance, all these in keep in mind, so we can decide the dose, and after the operation when we have to restart the dose. Am I clear?
Yes. So how, like where I am going to apply, how to apply this to my patient? This,
You can see here low risk, intermediate risk, high risk, and this very high risk is the pink. Okay,
yes,
then
Yeah.
we can read it
Mhm.
here. Any patient that is admitted from you can read it from this form. Patient admitted on day 3 and start. This is the protocol. If you want to start on the bridge, and this is a dose. I am clear. Okay. Then if the patient is very high risk, because over patient is mechanical heart wall and more risk factor and weight is 100, so over patient categorized in the very high risk. So we will admit the patient and switch on the unfractionated heparin. Okay.
Right.
And as how to calculate the dose, then you come down. There is one here you can see the we have to look at the creatinine clearance, and you check on here in the blueprint. In our patient, weight is more than 100. Overweight is 100. Okay. And creatinine clearance, we will go there in the blue box. A creatinine clearance less than 30 ml per minute. Okay.
Okay. Yes.
So what will be the dose? Can you calculate now? Look at the weight and go to the bluish to till creatinine clearance, because our patient has creatinine clearance less than 25 ml per minute.
So this is 5,000 here.
Yes, 5,000 international unit. You can give this bridging prophylaxis, but our patient is high risk. So and mechanical wall. So this is for the prophylactic dose, and our patient need therapeutical dose of
Yes.
bridging. Am I clear so far?
Yes. Yes. So how we will give this treatment dose?
Um,
Yeah.
mm,
If I go to G, I cannot see anything here. 100 kilogram.
Yes, if for therapeutical dose, then we can calculate by weight. Like every weight, we can use 1 milligram per kg. In if we use in the milligrams, are you following me? Like our patient is 100 milligram, then we can use 100 milligram per kg. Okay, mean if 40 milligram, mean it is 4,000 international unit, mean our patient need 10,000 international unit of therapeutical dose. And if you want, you can divide it into two parts, mean 500 in morning and 500,000 in the night shift. Am I clear so far?
All right. Yes. And what to do after the procedure, after the operation?
After the operation, after if the patient has a general anesthesia, then and the patient can after if the surgery is done by general anesthesia, then risk of there is no more risk of bleeding. Then and patient is stable, can take oral, then she can start her oral therapy. Okay, and if the patient gets spinal anesthesia, then after 4 hours of the spinal anesthesia, she can start her oral um,
Mhm.
thromboprophylaxis.
All right.
And we clear so far.
Yes. Okay.
And
Mm.
do you have any question, Diana?
Okay, and what about the renal function test in this patient? I mean, sorry, the anti-10A level monitoring. Is it required in my patient?
Yes, we can. If if any patient weight is less than 50 and or more than 90, then we can monitor the anti-10A level.
Mhm.
Okay, and any patient with renal function test, I mean renal failure, then
Yes.
we have to monitor the anti-10A level. Like in our patient, because she has a renal failure and weight is also 100 kg, then we have to monitor the anti-10A level to see she is taking adequate dose of thromboprophylaxis or not.
Right. And any other investigations to be done before changing the patient to the oral anticoagulant?
Um, sorry, doctor, actually, I didn't read this topic before.
It's okay. Well done. Good attempt. Even if you did not read, very good attempt, because I never liked this topic when I was preparing for my exam. Okay.
Yes, I didn't read even, I didn't look at this graph before. Sorry.
Good attempt. No issues at all. No problem. No problem at all. So communication was absolutely fine, my dear. So one colleague is me. All right. One colleague is Dana Green. What about the other colleagues in this one? What do you say, people? Anyone? Who would you like to involve in patients?
Yes, we will involve hematologist.
That's
Yes, we will involve our colleague because she is renal failure, hematologist, nephrologist,
exactly.
and
Yes, and
oncologist.
oncologist also, if you wish, you can involve, right? Because she's a endometrial cancer patient. Important ones will be your consultant,
Yes,
nephrologist,
oncologist,
yes, nephrologist. Okay, she is
yes,
stable and
nephrologist and hematologist to adjust the dose of heparin.
Hematologist is a very important one because you are doing the bridging thermal prophylaxis. You will get to want to in communication with colleague. Very easy domain to pass. C&E station involve all the colleagues. Even if you are involving 2 or 3 unnecessary colleagues, they are not going to detect any mark. There's no negative marking. But if you are missing someone, then you will not get the marks. So involve all your colleagues. All right. Hematologist, very, very important. Information gathering part was absolutely fine. So what about your patient? What information gathering is when we are talking to the junior and asking, how are you doing? What do you know about this? Have you read about this topic? And another information gathering is related to your case. So can you tell me more about your patient? All right, so he will tell she's 53 years and she has endometrial cancer. She's going for this major surgery. She has this mechanical heart valve. She's on warfarin and this. All right. Patient safety will be how you are. When are you going to admit the patient? When are you going to stop the warfarin? When are you going to start the IV and fractionated heparin? Everything is given in the flow chart. So we will see that. Applied clinical knowledge, how you are talking about the bridging thromboprophylaxis. So let's start. All right. So initially it's going to be a little bit of introduction. All right. So hello, I'm Bushra and you are. Hi, Dinah. Nice to meet you. How are you doing today? How's everything in the department? How about your colleagues? Are you enjoying being with us? Oh, that's really good to know. I understand you want to know about bridging thromboprophylaxis. Am I right? One thing. When you see any scenario, please don't assume that she has joined the department recently. They have not mentioned anything here that she has joined the department recently. Very small point. Just come to the point. So I understand that you want to know about the bridging thromboprophylaxis. Am I right? Okay. If it was mentioned she has joined the department recently, then you can say, I can see you have joined the department recently. Take care of that. Don't bring up anything from your side. Okay. That is situation awareness. Okay. So, do you have any idea about it? It's very difficult topic for me. No worries. We will discuss it together. And I will also explain what bridging thromboprophylaxis means, its importance, and how it is done. I will also give you the important articles and links and talk article. Is that okay? Is there any other concern which you want me to address today? Is there anything in particular which you want to know about the bridging thromboprophylaxis? All right. So then what is bridging thromboprophylaxis? Just little bit of introduction. You know, it means replacing the long-acting oral anticoagulant to short-acting anticoagulants like heparin in patients going for elective surgery. Why is it done? This is done until a patient can safely restart the oral anticoagulant after the procedure. This helps to reduce the risk of major intraoperative and postoperative bleeding. So, what is bridging thromboprophylaxis? Can you repeat? Excellent. And why do we do this? because if we stop oral anticoagulant simply, then this will increase the risk of clots. And if you continue the oral anticoagulants, this will increase the risk of bleeding. So what is the concept? Concept is giving an alternative anticoagulant like injectables, for example, heparin, with shorter half-life and which are short-acting because their side effects can be readily reversed and managed. Okay. Any questions so far? All right. So now coming to our patient, it is very important to assess the risk factors for thrombosis. So how are we going to assess the risk factor? By taking the history, like information gathering, examination, and from the investigation of the patients. So this will help to classify our patient into low risk, intermediate risk, high risk, or very high risk. Then comes your information gathering part. So what are the risk factors in our patient? Can you tell me? Age 53, weight 100 kilograms, any medical condition? Okay. She has endometrial carcinoma with mechanical heart valve. Any investigations done? Yes. Renal function test, creatinine clearance is only 25. All right. So it is very important to assess the risk factors to classify the patient. This will help us to know the dose of heparin to be given to the patient, either therapeutic dose or prophylactic dose. All right. So now we have to see the category of our patient. So let's go to your protocol. So we can start from the left side. It is a very nice color-coded protocol. Okay, so how are we going to categorize of the patient? Low risk, intermediate risk, high risk, very high risk. So our patient is having mechanical cardiac valves. So she comes in the very high risk. So we have to see this gray column. Now, we will also take the history from the patient. It is very important to see whether the patient has antithrombin deficiency or antiphospholipid antibodies. Before starting the heparin, it is very important to rule out allergy to heparin, whether she has any history of heparin-induced thrombocytopenia. So she has no history. That's okay. Now, when are we going to admit our patient? As she's going to have a surgery. So we will admit our patient. Just a minute. Here it is written admit patient, okay, on day -3. And before that, we have to stop the heparin, last dose of warfarin, because she's on warfarin. 4 days before the procedure, day -4. The concept is clear for everyone, right? Day -4. So if the procedure will be on the Friday, so we will stop warfarin 4 days before the procedure, isn't it? So Sunday or Monday, it will be like that. Suppose she's having it on 10th September. So day -4, 10 -4. So 6th, we will be stopping the warfarin. And when are we going to admit the patient? Patient is admitted on day -3. So 10th September -3, 7th September. Okay, so we will be admitting the patient. Then we can start IV and fractionated heparin after ruling out all the contraindications to it. And the important investigation is INR. So INR has to be less than 2. Before the surgery, we have to stop unfractionated heparin at least 4 hours before the surgery. Now here, what you will do in the exam, whatever flowchart is there, categorize the patient correctly and then follow that flowchart in the exam. And post-operatively, when are we going to start the unfractionated heparin? So as soon as the bleeding has stopped, okay? And if patient has a epidural insertion, then we will wait for at least 2 hours. If she has any traumatic epidural insertion, then we have to wait for at least 24 hours. And we always have to involve the hematologist in the care of this patient. Now, what about the low molecular weight heparin? So actually, this is unlicensed, you know. So whenever we are starting this low molecular weight heparin, so again, it has to be after discussion with the hematologist because it is unlicensed. So what about the dose of low molecular weight heparin if we have to start. So go to your, like they have mentioned, check renal function, CE. So first, if you will go to E, what they have mentioned here, bridging therapy in renal failure, they have mentioned refer to table F for prophylactic dalteparin. And so let's go to F first for prophylactic dalteparin. So what they have mentioned, we have to see the weight of our patient. So our patient's weight was 100 kilogram. What about the creatine clearance? It was 25, less than 30. So what will be the dose? 5,000 units. All right. Then here they have mentioned refer to table G for the treatment dose. So let's go to the table G for the treatment dose. Patient's weight is 100 kilograms, so more than 83. This is 83, okay? So more than 100. Now what's going to be the dose? Creatine clearance is less than 30. It was 25, so this will be the dose, 12,500 units. So the junior asked, is there any role of anti-10A monitoring in our patient? Yes, there is a role. So like you said, Bushra, if the weight is less than 50 or more than 90, so our patient's weight is 100 kilogram, plus she has end-stage renal condition, so we will be monitoring the anti-10A level. All right. Now, what about the further like restarting of the oral anticoagulant because patient was on warfarin? So again, we have to check the INR. All right. So whenever INR is in the normal range, then we can start the warfarin. So again, we have to take the help of the hematologist, involve the consultant also in this patient's care. Also, we have to involve the nephrologist. And if you have time, then you just explain whatever is written in the box. Okay, then you can talk. He asked a little bit about the enhanced recovery program. So this patient is such a high risk. So what about the enhanced recovery program in this patient? Yes, so you have heard about the enhanced recovery program. That's very good to know. All right. One thing, I'm not going to repeat everything here because I have explained everything on the chart. All right. So I'll go to principles of enhanced recovery program. Now, just a minute. Follow-up is also given in the flow chart. So what about the follow-up? It will be in the local anticoagulation clinic. Everything is in the box. Okay, this is from the box which I have written that within 3 days, if there is only one INR in range, and within 5 days, if 2 consecutive INRs are in the range. All right, so what about the anti-10A level monitoring? So yes, we are going to do in patients with renal failure and those with weight less than 50 kilograms or weight more than 90 kilograms. All right. Now, just to summarize what we will do, we have to stop the oral anticoagulant 4 days before the surgery, and heparin is given from 3 days before the surgery. We remember this from the chart, isn't it? Day -4 and day -3, depending upon the target INR. So this is a very important investigation to be done in this patient, international normalized ratio. All right. When are we going to start the heparin? After the surgery, when the bleeding risk is less. And oral anticoagulant, that is warfarin, is also started only when it is safe to do so. And usually we do it on the evening of the surgery when epidural catheter has been removed, when there is no excessive bleeding and when target INR is reached. MDT, involve the consultant, involve the hematologist, and also you can involve the nephrologist and oncologist in her care. All right, so principles of enhanced recovery program, yes, it is very important. So what we will do preoperatively, we have to check the patient's hemoglobin, treat the anemia, optimize hemoglobin, because there is increased risk of bleeding. Rule out if she has any reservations for blood transfusion. And also we can use the intraoperative cell salvage if she has reservations for blood transfusion. Then plan for bridging through prophylaxis. It has to be done by the MDT and we are going to document everything. Intraoperatively, how to reduce the risk. So again, we have to involve the consultant and seniors in the surgery. Meticulous surgical technique has to be used, minimal invasive surgery, secure hemostasis, use hemostatic agents, use intraoperative cell salvage, and drains can also be used postoperatively. So patient may need admission in HDU, kept under close observation, maintain the news chart, offer elastic compressions, encourage early mobilization, maintain adequate hydration to reduce the risk of thrombosis. Start heparin once bleeding is stopped. Antidote should always be ready. Okay, what is the antidote for heparin and warfarin? Can anyone say
For warfarin, vitamin K,
yes?
and protamine for heparin.
Yes, protamine sulfate for heparin. Yeah, vitamin K for warfarin. All right. And if a patient is at very high risk of thrombosis, she had any like recent thrombosis, in that case, surgery can be deferred until the risk of thrombosis is low. So preoperative assessment and risk assessment of thrombosis is very important in these patients. All right. So why? Because this will help to give effective perioperative anticoagulation, and we can plan the perioperative anticoagulation therapy. So how did it go? How was the session? I know it's a bit difficult topic, but I hope my explanation was helpful to you. If you have any other query, please feel free to ask me. All right, I will give the important articles on bridging thromboprophylaxis. Thank you. Have a nice day. It was difficult station when it came for the first time, but the only thing is that you people have to follow the flow chart. There will be some clue given, and once you see that clue in which category your patient is, just follow that chart. That's all. And if the junior asks about enhanced recovery program or anything and you know about that, then explain that, because that's going to fetch you marks. All right, Bushra, well done. So I think we have 3 active participants today. Other 3 will not be joining. Okay, so I will start again with Shweta. Okay.
Yes,
All
I'll
right.
start.
Okay, fine. Just one slide, take you 2 minutes.
Yes. Hello, I am Shweta, one of the ST5, and you are?
Yes, I'm Julia Smith.
Yeah, nice to meet you, Julia. How are you doing?
I'm good, thank you.
Yeah, I can see that you have recently joined the hospital. So how is everything going on? Have you well adjusted in the hospital?
Oh yes, everything is going on fine, and yes, I'm well adjusted here.
Yeah, good to know that, Julia. So, Julia, I understand that you have wanted to learn about the breech delivery. So, is it so?
Yes.
Very good. Julia, this is very important topic because sometimes we get undiagnosed breech. So we don't know, and during the delivery breech happens. So we must know how to do the delivery of breech. Okay.
Yes.
So may I know what do you know about the breech delivery?
Well, not much, that day I saw this breech, she
Mm-hmm.
was fully dilated, and
Mm-hmm.
they delivered her, and they were talking about some maneuvers, how to deliver the legs and arms and head. So I want to know about that as well. And
Yeah.
yeah, that's all I know.
Yeah, Very good, Julia. So these things are very important. Knowing the maneuver are very important. So we'll go through that today. And before that, we have to follow some protocols. Okay. So
Mhm.
for assisted breech delivery, we cannot do in every patient. So there are some contraindications. There are some indications. Okay, and we have to follow some protocol. So for the indications, like we cannot do breech delivery at all where where the baby weight is more than 3.8 kg, head is extended. During the scan, we found that head is extended, and when there is footling breech. Okay, in
Yes.
these and when there are the absolute indication for cesarean section like placenta previa, in that case we should not try the breech delivery. Are you following me?
Yes. Okay.
Yeah, and for the breech delivery, we should be like some trained persons should be doing that. Untrained persons should not be there. Okay, and we should have our team like pediatrician and OT team, anesthetist, all should be alerted. Okay, and patient should be informed before that, and informed consent, verbal consent would be there. Then patient should lie on the lithotomy position, and however the standing position can also work. Okay, it depends on the patient choice. And after that, bladder should be emptied, and then patient buttocks should be on the edge, and most important thing is that we have to follow the hands off attitude. Okay, do you know what is hands off attitude?
Yes, we should not touch the patient and the baby,
Yes.
right?
Yes, very good, very good. It seems that you already know about it, okay? And you are so after that, we wait till the umbilicus of baby is delivered. Okay, so because if we touch, then there are chances that head or arm that can extend, and also the umbilical cord can get touched and vasospasm can happen. So hands-on approach is very important. And after that, if a leg are flexed, then it would come automatically out. If it doesn't come, like if leg is extended, then what we do the Pinard maneuver. Like Pinard maneuver is that like we just put two finger in the popliteal fossa and hook the and just press it and hook the hold the baby with foot and then pull it down. Okay, then
Ye-
in similar manner, the second leg would be delivered. Are you following me?
Yes. Okay.
And you can see here the baby is this pelvis and baby is given. The here you can see that legs are extended.
Yes.
So what I told you, that just put two finger into the this fossa, popliteal fossa, and hook it
Yeah.
out. Okay.
Yeah. Yeah.
Yes, very good. You are following well. And after that, we have to wait. That one thing also we have to follow, that keep the always back anterior. Baby should not rotate. So if baby there is tendency of rotation of baby, then what we do, we just hold the baby with at the bony prominence like femoropelvic grip. Okay, to keep the back anterior. Can you tell me which grip or where we hold the baby?
Yes, you told femoropelvic grip at the bony prominence.
Yes, very good, very good. You seems to be a very fast learner. Okay, so after that we wait till the scapula is visible. So if we see that there is scapula is normal, then it means that arms would be flexed. If there is winging of scapula, that means that the arm would be either extended, or a nuchal arm, like arm would be behind the back of the neck. Are you
Mhm.
following me?
Yes. Okay.
Okay, so after that, if the arms are flexed, then we can just pull out. If flexed, then it will come automatically out. And if it is extended, then we do the same maneuver, like hooking out the elbow and just pull in the straight direction, sweeping over the chest, so that there is no harm to the humerus bone. Okay.
Yes.
Okay. And
So
after that,
what is
yes.
that maneuver? For the delivery of the arm?
We call it, this is also a extended arm. This is pinard maneuver.
Right. Okay.
And if the arm is ducal, like it is on the backside of neck, then we called it lopset maneuver. We deliver the arm by lopset. Here, what we do, we just rotate the baby by holding in femoropelvic grip, like in just rotate
Yes.
in 180 degree, so that the arm gets released. Okay.
Mhm.
And
Yes.
after the release of arm, we just hook out like elbow and pull it out. And in this manner, the both arms are uh, uh, delivered. And we have to be just careful that we should not be in hurry, okay? So that we should not harm any bone in of baby. And after that, the head should deliver. We always keep make sure that delivery of head and buttock should be between the, less than 5 minutes, and from umbilicus to head should deliver within 3 minutes. So we have to be we have to keep these things in mind. So after that, if we wait till the nape of neck is visible, okay, we will not touch, and then we allow the baby to hang. So that nape, when the nape of neck is being visible, then there are two methods to deliver the head. One is called Mauricio Meli weight, and one is forceps. So do you know about this maneuver?
No, I don't know.
Yes, we'll go to that. So in first maneuver, what we do, that we keep the baby in our non-dominant head in horse riding pattern, and then both non-dominant hand fingered, like two fingers, like index finger and middle finger would be on the malar eminence, and let's be sure that it should not be in the mouth. And the dominant hand, we put the two finger of our dominant hand like on both shoulder, and middle finger on the occiput to keep it flexed. Okay. So
Yes.
by flexion, it decreases the diameter and head would be deliver out. So if this doesn't happen, then we will go for forceps. So there are special forceps for that. We call it Piper's forceps. Can you tell me the name of forceps?
Pipers.
Yes, this is actually long forceps, and it has three curve, like perineal curve and pelvic curve, and then there are three, and it has three part, like perineal part and pelvic. Sorry, I got confused. After that, we with the help of forceps, we deliver the head, and we apply forceps like normally what we do in cephalic presentation. Okay.
Mm-hmm. Yes.
Okay. And during the meantime, we keep patient informed that what we are doing, and we check proper analgesia as well, so that pain should not be there. Okay.
Mm-hmm. Yes.
And after that procedure, then after delivery of baby, hand over baby to the pediatrician. Pediatrician will check baby about any injury, and then cord blood sample would be sent, and then we do the active management of third stage of labor, deliver the placenta, and check about the injury, because there are chances of injury to perineum, and there are chances of bleeding as well. So we check, we do the PV and rectal examination, vaginal examination thoroughly, and then we after that we check the instruments, swabs, all the things, and then documentation should always be there. Okay.
Fine. Good. Okay.
Okay. So now, any concern you have? Anything you want to know more?
No, you have explained to me very nicely. So it
Okay.
was
Now yes, very good. So I'll give you the reading material about that, and also you have RCOG and Stratology site are there. You can go and see the video about that. Okay. So how is the session today?
yes, very good. Very good. And you
Okay.
finished on time. Well done.
Okay. Thank you.
Very
Thanks
nice.
for
Okay. So
I was scared that I'll make it on time or not.
very nice. And you have covered all the points. So communication with colleagues, one is me, and you told about trained person.
Pediatrician. Yes, pediatrician and OT team, anesthetist, and
Yes, also inform your consultant when this.
consultant.
Yeah.
Yes, I
Yes.
forgot.
Yes, so that will complete your communication with colleagues 2 by 2. Patient safety, contraindications, you told the prerequisites, and no touch technique, hands off. holding the baby at the bony prominence, keeping the back anterior. Those things are all your patient safety points. Applied clinical knowledge, how you are doing this assisted vaginal breech delivery and showing everything to the junior. So yes, and the maneuvers. So for the leg, it is Pinards, right? And arms, love sets, head, Mauritius Malavid technique or the Piper's forceps. From my side, it will be a complete pass in all domains. Okay.
Thank you.
Well done. Good. So all of you are like very happy when you're talking to the junior today. So it has to be like that in the exam. There has to be a smile on your face, and your communication, the introduction has to be very nice, being like happy communication. Okay, so hello, I'm Shweta and you are? Hi, Julia, how are you? Nice to meet you. And how's everything in the department? How are your colleagues? Are you enjoying being with us? Okay, it's nice to know that you're enjoying being with us in the department. I understand you want to learn more, learn about the vaginal breech delivery. Am I right? So is there any other concern which you want me to address today? May I know why do you want to know about the breech delivery? What exactly would you like to know? Have you read anything about it? So what I will be discussing with you is I will be talking to you about the vaginal breech delivery, what are the prerequisites for it, what are the contraindications, and how we conduct the vaginal breech delivery. Is that okay? Is there anything else you want to know? All right, then I will also be like you can also have the hands on once we end the session. And during our session, please feel free to ask any question at any time. And yes, you can say a few lines like, I really appreciate your eagerness to learn. And like, it's very good that you have chosen this topic. So, and by the end of the session, I will give you important articles and guidelines and some RCOG videos on the breech delivery. Is that okay? And I would be happy to get a feedback from you as well, that how was the session and how I can improve it. So coming to the prerequisites, you know, these are very important patient safety point. There has to be appropriate case selection whenever we do the breech delivery. So we have to be very safe, and like we have to rule out the contraindications. So do you have any idea about the contraindications? All right, so one is footling breech, extended neck, and like weight of the baby, if it is more than 3.8 kilogram or less than 10th centile, placenta previa, and when there is absolute indication for cesarean section. So can you repeat some of the contraindications? Well done, you're a fast learner. And also, like, we can have a look at the patient's notes, and delivery has to be done by the experienced clinician, and it should be done in a tertiary hospital with facilities for immediate cesarean section if any emergency arises. Yes, my dear, don't forget about the continuous electronic fetal monitoring. I will make it red. It has got asterisks, even I forgot. So there has to be continuous electronic fetal monitoring or CTG. And we should also strictly adhere to the protocols. All right, so can you repeat some prerequisites? Fine, well done. Now, once woman is fully dilated and she comes to the labor room, then we have to inform the senior staffs, because, you know, breech delivery is a high-risk case. So you will be informing the consultant, pediatrician, anesthetist, operation theater, because you may need to take her to the theater in case the breech delivery fails and if she needs cesarean section or there is fetal distress. Now, how do we conduct the breech delivery? So you will stand in front of the mom, introduce yourself, bring her to the edge of the table, and explain to her what's going on. Ask the nurse to empty the bladder, maintain the hands off, and wait for the descent till umbilicus so that the legs come out on their own. All right, so this is for the flexed breech. All right, and here we will assess for episiotomy. So assisted breech delivery is done in extended breech, right? So here what we have to do, we have to assist the delivery of the legs. You explained it very well, Shweta. So what we will do, we will insert 2 fingers, go inside, palpate the popliteal fossa, press it, flex it, and grab the food and deliver. And this is known as the Pinard's maneuver. Can you show me how to deliver on the other foot? Well done. After that, we are going to wrap the baby in warm towel, wait for the abdomen or trunk to deliver. Avoid handling of umbilical cord. It can cause vasospasm. This is also patient safety. Now, sometimes what happens, baby can rotate from anterior to posterior. So at all times, we have to keep the baby's back anterior. How we are going to do that? By holding baby gently on the bony prominence. That is your femoropelvic girdle. Fine. So we will hold the pelvic girdle to avoid any injury to the internal organs and avoid tactile stimulation. What happens that, of course, if we are going to hold the baby on the soft tissues, then it will cause the tactile stimulation, and this can cause extension of the baby's neck. And then there will be difficulty in delivering the baby's head. All right, then you can just ask your junior, how are we going to hold the baby on the bony prominence? Well done. All right, so now coming to delivery of the arms. Now we have to wait for the arms to be delivered. Sometimes arms are extended or nuchal arm. So here again, we have to assist in the delivery. We will hold the baby at the pelvic girdle, and you have to place the thumbs at lower back parallel to the fetal spines. Then we are going to apply gentle downward traction, rotate the fetus. So here, this is like, just imagine that you're rotating the fetus through 90 degrees so that posterior shoulder will come under the pubic symphysis. All right. Then you will be inserting the two fingers, reach up to the elbow joint and palpate the cubital fossa, press it, flex it, and then sweep the arm across the chest and deliver it. So after that, you have to deliver the other arm. Then now again, we have to rotate the fetus double. First, we rotated through 90 degrees. Now we are going to rotate through 180 degrees. So other shoulder will come under pubic symphysis. Then again, we are going to deliver it in the same way. Go up to the cubital fossa, flex it, and then deliver the arms. All right, this is the Lovset's maneuver. Now, what about the delivery of the head? Again, you have to keep the hands off. And once nape of the neck is visible, then we will deliver the head. So it can be done by two methods, Mauritius-Malievite technique or forceps. And forceps used is the Piper forceps. If Piper is not available, then we can use the key-length forceps. So what about this Mauritius-Malievite technique? Again, you will imagine, place the baby on your non-dominant hand, okay, and let it hang like this. Then you will place the index and ring finger of this non-dominant hand on the baby's malar prominence. Now, you will use your dominant hand, and you will use the index and ring finger of your dominant hand, place it on the baby's shoulders, middle finger will be on the occiput. Then you will ask your assistant to give the suprapubic pressure, and at the same time with contractions, you will be flexing the head and delivering the baby gently. So suprapubic pressure will also help to maintain the flexion of the head. All right, then after delivery, once the baby is born, clamp and cut the cord and hand over to the pediatrician. All right. And then, we have to send the cord blood samples for arterial blood gas analysis, complete your vaginal and rectal examination. And any examination has to be done only with the patient's permission and in the presence of chaperone. If there is any tear or episiotomy given, we have to repair it. Midwife will complete the counts, and we have to complete the documentation and debrief the mother. So do you have any questions? How was the session? How did it go? And then give the articles on breech delivery. Then, okay, just remember this. This was a question asked by the junior in the exam. What was the delivery? What is the delivery time from buttocks to head? So 5 minutes. And from umbilicus to head, it is 3 minutes. Okay, good. Well done otherwise. You people are practicing. That's good to know. Okay, thank you, Shweta. Next.
Thank you.
Okay, welcome. Maria, right? So today is your day, 3 people. So you will all get 2 cases. That's good. The more you practice, the more it will help you in your preparation. Yes. Yes, Maria, would you like to do this one? I can't hear anything from Maria.
Yes, doctor, I can do.
Yes, okay. Yes, Bhushan.
I'm doing, Doctor. I was just talking to you. I don't know why, because I think I was.
Okay, no problem. Okay, okay, Maria. After Maria, it will be Bushra. We have 6 stations only. All right.
Right.
Okay.
So, am I audible now? Am I audible?
Yes, you're audible. You have
All
to.
right.
Yes, one thing, just for the sake of our station, because these were very small blocks. So keep it 10 minutes here and 10 minutes graph here so that it will be easy for us to understand. Okay.
20 minutes. Right.
20 minutes. All right. Okay. Your time starts now.
Okay. Hello, I'm Maria, and you are?
Hi, I'm Emily Carter.
Hi, Emily. How are you doing?
I'm fine.
Okay, so how's going everything in department?
Yeah, everything is very good.
How about your colleagues?
Oh, yes, they are all very nice and very cooperative.
That's good to know. Well, Emily, I understand you are here because you want to learn about the CTG. Am I right?
Yes.
All right. So may I ask, why do you want to know about the CTG?
Well, when I was in the labor room, so I was there a little while ago, and then this midwife, she showed me the CTG. There is a patient there, and she wanted me to comment on the CTG, and she wanted me to categorize it. But I completely forgot to read the CTG. I don't know what are these dips, what is this. I just forgot everything. So that's why I want to know about it. In fact, I want to know everything about the CTG.
It's really good to know, Emily. I really appreciate you are so eager for learning. Well, we are going to discuss in detail about the CTG today, okay? And I will try my level best to tell you about that, what is the CTG, what are the prerequisites for the CTG, and how we interpret the CTG graph, okay? So, do you have any other concern you want to discuss with me?
No, I just want to know about the CTG. That's all, and about the management of this patient. That's all.
Okay, all right. And only one thing more. Yes, I'm also be giving you some important material, related to the CTG. Some links of the RCOG as well as STATOG, which are really going to help you to know more about the CTG. Okay.
Yes.
Okay, and I would appreciate if you give me a feedback at the end of the session, and you have to tell us that how was it, where we need to improve more. Okay.
Yes.
Okay, all right, Emily. Emily, can you tell me what is CTG?
I know the full form. It is cardiotocography, isn't it?
Very good. So what does it shows? What does it tells?
We will see the baby's heart rate and uterine contractions.
Very good, Emily. You are absolutely right. Basically, CTG is an electronic device which tells us about the fetal heart rate as well as about the uterine contraction. Okay, so whenever you will see the trace of the CTG, you will see there are two components. Upper one will show the fetal heart rate and the lower one will show the uterine contraction. Okay, Emily. And Emily, there are some prerequisites for the CTG. Whenever we do the CTG for any patient, we need to confirm these prerequisites. Do you have any idea about it?
No, I don't know.
Okay. We need to confirm that CTG machine is working properly. It is displaying time and date properly. Also, we need to confirm that paper is running freely in CTG machine. And also, there should be a CTG speed in 1 centimeter per minute. Okay.
Yes.
Once we have confirmed it, then we will definitely will apply on the patient. And you know how we interpret the CTG? Do you have any idea?
No, I don't know.
Okay, let me tell you in an easy way. There's a one mnemonic, we call it Dr. C. Bravdo. Have you ever heard about it?
Oh, well, they were talking in the labor room the other day about this mnemonic. So can you explain to me?
Yes, sure, Emily. I'm going to explain it, and I'm sure after listening it, and you will be able to interpret the CTG. Okay. So, Emily, basically, this Dr. C. Bravdo, DR indicating the determined risk, and C is for the contraction, BR is for the baseline heart rate, and V is for variability, and A is for acceleration, D is for decelerations, and O is for the overall assessment. Okay. So what we do in CTG, first we have to take the history from the patient before doing the CTG, right? So we have to find out the risk factors. Like we have to confirm whether it is a term pregnancy or preterm pregnancy, whether it is a singleton or twin pregnancy or multiple pregnancy, we can say, or mothers having some other comorbids, like maybe mothers having a diabetes, hypertension, preeclampsia, or any other problem, right? So once we have confirmed that there's no such issue, then definitely we will be confirmed that CTG will not have these changes. Because let's suppose if mothers also, apart from this, observations are very important. We need to check vitals, like might be mothers having fever. Let's suppose mother is having fever, so mother will be definitely tachycardic. Okay, so baby will show same pattern. So for this, it is very important to find out these risk factor in the history, right? After that, there's the C. C indicates, as I told you, about the uterine contraction. Do you know how many contractions should be there in 10 minutes?
5.
5 contractions. So you said that 5 for how long? In 10 minutes?
Yes, I think so.
Okay. MD, actually, contraction, there should be less than 5. We can say 3, 4. Okay, these will be acceptable. Once contractions are 5 or more, then it will be the another feature of the CTG. It will be not a white feature. Do you know about the features of the CTG? There are the white, amber, and the red feature. Okay, so if in CTG uterine contractions are 3 or 4 in a 10-minute race, they will be considered as a white feature. But if it is a more than 5 or more than 5, then it will come in the amber feature, right? So it is very important to know about these things. And now come to the other factor, that is the component, that is the fetal heart rate, right? Normally, baseline of the fetal heart rate is from the 110 to 160, right?
Yes.
If it is less than 110, I mean, it is between 101 to 109, then we consider it as a amber feature. And if it is less than 100, then it will be the red feature. Similarly, if it is a more than 160 tachycardic, then again it will come in the red feature, right? So we should have a knowledge about these features too. Then come to the variability. Do you have any idea about the variability?
No.
Variability is basically a fluctuation of the heartbeat, and it is showing that how baby's autonomic nervous system is working, right? And it is normally in between 5 to 25. If it is a less than 5, again, it will come in amber feature.
Okay.
And if it is a more than 25, so again, it can be an amber or it comes in red feature, right? Then come to the another feature, that is the acceleration. What do you mean by the acceleration?
There is the heartbeat goes up, isn't it?
Very good. For how long?
I don't know.
Yes, there should be a rising of the heartbeat 15 beats in 15 seconds from the baseline, call it accelerations. Just opposite it, then it will be the decelerations. Means when there will be the dropping of the fetal heart rate 15 beats in a 10 seconds, then it will be decelerations. Do you have idea about what are the different types of the decelerations?
Yes, I know, like early, variable, late. So can you tell me about in this CTG, like how to read it?
Yes, Emily, I'm coming to your patient CTG. You see that this is a total graph of the 20 minutes, right? If you see in a 10 minutes graph that it is showing that there are the 3 contractions, and I told you that contractions should be 3 to 4 in 10 minutes. So these will be the normal contraction. And if you show in fetal component, the heartbeat of the fetus is the 120, okay, baseline. So again, it is a normal because we earlier discussed that it should be between the 110 to 160. All right. So it is a 120, it is a normal, but there you see these dips. There are these 2 dips, which are matched to the uterine contraction. So these dips are what? These are the early decelerations. Early decelerations basically occurs with uterine contractions. Okay. As uterine contraction will start, dip will start. As uterine contraction will down, then dip will be stopped.
Yeah.
Similarly, the third one, this one you see, that is the late deceleration. Why? It is occurring after the contraction. Okay. In late deceleration, what happen? There may or there may not be, it come back into the, baseline of the fetal heart rate. So if you see this whole trace, you will find there are the 4 early decelerations and there are the 2 late decelerations, right? So what we will label it? Yeah.
I don't know, maybe suspicious or pathological?
In overall assessment, yes, we can say this is a suspicious CTG. Why? Because it has got one amber feature, and that is the late deceleration, right? So, Emily, when there's any one amber feature, we call the CTG suspicious CTG. If all features are normal, then it will be it will be the normal CTG because it contains all white features, right? But this CTG is containing one amber feature. So this is a suspicious CTG. So how we are going to manage this patient?
Yes, that's what I want to know. Patient is in the midwifery unit. So what should I do now?
Can you tell me about her history? So what were her history?
She is primary gravida, and she is now 6 centimeters dilated, and midwife was saying she is also having thick meconium stain like her.
All right. So Emily, you see her CTG is a suspicious. So first of all, we will go for the conservative management, in which what we will do, we will keep the patient on left lateral position and we will start IV hydration, okay? And we will continue the CTG. And then we will later on monitor if patient, his CTG is getting better by these measurements, then well and good. But if it is, these are not, getting improvement or CTG become a pathological, then we need to expedite the delivery. Okay. So what we will do, then we will definitely prepare the patient for the cesarean section.
So
all right.
We will not take the fetal blood sample?
No, Emily, nowadays it is not recommended. We don't fetal blood sampling.
Good. Close the station. Okay.
Okay. So Emily, that is all about the CTG. Do you have any other question regarding the CTG?
No, it's very clear now. I can read the CTG very well. Yeah.
Yeah, as I told you earlier, that I'm also going to give you some, important links and as well as materials related to the CTG. That is really going to help you a lot. And also, I will suggest you that in labor room, you try to see more and more CTGs of different patients. In this way, you will be confident enough to pick the findings. Okay.
Yes. Okay. Thank you.
Thank you so
much. Well,
okay.
Well done. Just everything was absolutely fine. I will just tell you how to save the time in this CTG station. Information gathering, yes, one is me and other is your patient. You have to ask about the patient. Good. Communication with colleague, yes. In this case, we have to involve the senior midwife, consultant. All right. And applied clinical knowledge was absolutely fine. So it was suspicious CTG, isn't it? Okay.
Yes.
She had late decelerations, right? And patient safety, now from the midwifery unit, we have to shift her to the consultant-led unit. And applied clinical knowledge, what you told about the management. So conservative management, no fetal blood sampling, that is also patient safety, taking her for the cesarean section if there is no change in the CTG. Fine. So When you're talking about the CTG, Dr. C. Bravado, you can just show the CTG itself. That first is determining the risk. And so what are the risks in your patients? These are the risks, like you said, multiple, twins, previous years. So may I know, and is there any risk in your patient? She will say thick meconium stain liquor is there now, all right. Then after that comes the contractions. So you tell the contractions and show the CTGs in the exam. So can you see how many contractions are there in 10 minutes? All right, 3. All right. Then you talk about the variability. So this is the variability. Normal is 5 to 25. Then when you're talking about the fetal heart rate, normal is between 110 to 160. So can you see 120? So, you are explaining and you are at the same time, like you will save your time. You're doing 2 in 1. You're explaining and then you're showing the CTGs. After you explain Dr. C. Bravado, there is very less time when you will explain the CTG. So do everything at the same time. This will save you time in the exam. Yes. Because even I did this mistake when I was preparing initially, but gradually when I started discussing it with my seniors and all, they said, do everything together so that this is going to save you time.
Right.
Right. Like how we do the breech delivery. We are not explaining the breech delivery and then coming to the mannequin. We are doing everything together, isn't it? So whatever there is in front of you, explain on that. It will save the time. Okay. So, hello, I'm Maria. And hi, Emily. How are you? Nice to meet you. I understand you've joined the department recently. How's everything in the department? How about your colleagues? Well, I understand you're here because you want to know about the CTG. Am I right? So may I know, why do you want to know about it? Do you have any idea about the CTG? Have you read the NICE guidelines? So she will say, I don't know anything about it. The NICE guideline is very vast. I don't know anything about it. All right, no worries. We will read the CTG together, and I will also be giving you some important articles on the CTG. Is there any other concern which you want me to address? All right, so I will discuss about CTG in detail, how we read it, the prerequisites, its importance, and then we will interpret the CTG together. And I would love to have feedback from you about my session. Now, coming to the CTG, may I know what do you understand exactly by it? Okay, so the full form is cardiotocography. Yes, it is electronic record of the fetal heart rate and contraction of the uterus. It has got 2 components. You can see we have 2 components here in the CTG. This is the upper component. This is the fetal heart rate trace. And the lower component, this is the uterine contraction. Okay. And when we are reading the CTG, we have to keep in mind some patient safety points. We have to confirm the patient's name, date of birth, and NHS number. And there are some prerequisites, like paper speed should be set at 1 centimeter per minute. The CTG machine should be checked. It should be working correctly. We have to ensure that there is correct time and date displayed, and paper in the machine should be running freely. Am I clear so far? Any questions? So what should be the prerequisites? All right, you're a very fast learner. Now, how we interpret the CTG? For that, we use a mnemonic, Dr. C. Bravado. Have you heard about it? So in the exam, you can just scribble it on a piece of paper and you can explain. So this is DR, it means determine risk. It means that we have to see what are the risk factors in the mother. So we will take the history from the mother, whether like it is term or preterm pregnancy, singleton, multiple, or if she has any medical comorbidities, diabetes, hypertension, etc. How about the baby, any decreased fetal movement, FGR, and how about the maternal observations? So do you have any idea about the risk in your patient? What is your patient's history? Okay, so she has thick meconium stain liquor, all right. And C stands for contraction. So normally, yes, you very rightly said it is 3 to less than 5 in 10 minutes. And if it is like that, then the CTG is color coded now. It is white. And if it is more than 5 in 10, then it will be amber. So can you see with me the contractions here? All right. So what do you think in 10 minutes? There are 3 contractions. So is it normal? Yes, this is normal. Over here also, There are 3 contractions. So this is normal. And then next, it is the baseline fetal heart rate. So normal is 110 to 160. This is again white. If less than 110, it is bradycardia. And 100 to 109 is amber. Less than 100 is red. And if more than 160, it is tachycardia, that is red. Okay, so you can just remember less than 100 red and more than 160 is also red. So what about our patient's baseline fetal heart rate? Can you see? It is 120. Very good. Now, V stands for variability. Normally, it is 5 to 25. What is variability? Do you have idea? It is the fluctuations in the fetal heart rate, and it shows that baby's autonomic nervous system is working normally. And you know, normal fetal heart rate and normal variability, these are good indicators of fetal well-being. Then coming to A, it is acceleration. So in this, there is transient increase in fetal heart rate from the baseline by 15 beats per minute for 15 seconds or more in a 20-minute period. And acceleration may or may not be always present. So let's see in our trace, is there any acceleration? Actually, this doesn't look like acceleration. This looks like variability only or some artifact. But just for this session, we take the acceleration. Okay, so we have one acceleration here and one is here. All right. So after that, there is deceleration. So what is deceleration? This is just the opposite of your acceleration. So what happens in this? There is decrease in fetal heart rate by 15 beats per minute for 10 seconds. And you know, there are 3 types, early, variable, and late. Do you have idea about them? All right, so just in brief, you can explain. Early deceleration is what we say, these are the mirror image of your contraction. They start with the contraction and end with the contraction. So this is the early deceleration. You can see this is just like the mirror image 1 and 2, and here also 1 and 2. Then we have variable decelerations. They can start before the contractions, with the contractions, or after the contractions. And like they can happen when there is cord compression. Early deceleration happens because of the head compression. Then we have one more, that is a late deceleration. Usually it starts after the contraction. So here you can see this deceleration. Don't you think so, that it is starting after the contraction? And sometimes it may not reach even the baseline here. So we have one late deceleration here, one late deceleration here. Okay, and then O stands for overall impression. So now we have to classify our CTG. A classification is either normal, suspicious, or pathological. So what do you think is happening here? When all 4 features, see, this all I have explained, okay? So I will not repeat all this. I will come here to the overall impression. So here, when all 4 features are white, it is a normal CTG. One feature is amber, so it is suspicious. And 2 or more features are amber and 1 feature is red, then it is pathological. So what is happening here? We have 2 late deceleration, but the CTG is only 20 minutes. So that is the suspicious CTG. Now, the patient is also having the meconium stained amniotic fluid. All right, so what do you think? How are we going to classify? It is the suspicious CTG. Any questions? All right, then she wants to know about the management, your junior. All right, so now we will communicate with the mother, her partner, and also the senior. We have to inform the consultant, the senior midwife. And you know, management decision should not be according to the CTG alone. We have to consider the whole clinical picture. So we will start with the conservative measures, changing the position to the left lateral, giving the IV fluids, and hydration. Oxygen we don't give routinely. Then we are going to do the fetal scalp stimulation and then review the CTG. If CTG is still not improving or becoming pathological, then we have to expedite the delivery. So we can use either the instruments or we have to prepare the patient for cesarean section. What about the fetal blood sampling? Yes, it is not recommended now because there is only limited evidence about the fetal blood sampling, and it is also very time consuming. All right, so your patient is in the midwifery unit. So what are we going to do? We have to transfer her to the consultant-led unit. Continue the CTG trace at least to assess for repeated late decelerations and start the conservative measurements. And we are also going to explain everything to the mother and document our discussion and the management plan. Okay, any questions? Fine. Then just your closing the station. How was the session? How did it go? So I hope you will be able to read the CTG now, and I will give you the important articles. And if you have any query, please feel free to contact me anytime. All right, now there was, okay. We have one more station, right? So there was, okay, for how long we can store the CTG? This was also the question asked.
25 years. And if the has any concern of fetal outcome, then for electronically safe for a long time.
Yes.
Otherwise, 5 years must.
Yes, yes. If any cerebral palsy or anything, then yes, for long duration we can store it. Okay. Okay, last station for you only. Bushra was talking. Hello.
Yes.
Yes, your station.
This is about partogram.
Yes, yes. You have two slides, not 5 slides, 2 slides. Can you do it?
Actually, today all station coming to me that I not prepared. And all I prepare not come to me. I don't know why this happening. Okay.
Okay.
No problem. This partogram.
Who will take it?
Anyone can take, no problem.
All right. So, Maria or Shweta? Labor care guide.
Yes, I can do it.
Okay, good. All right.
Next paper. Next slide.
Yes, this. So in the exam, it will be like this only, huh? Right.
Yeah, previous one, please. Previous. Yeah. Next paper, please. Next one.
Yes.
Yeah. Hello, I am Sweta, one of the ST5 and UI.
Yes, I'm Nita Joseph.
Yeah. So how can I call you? Can I call you Nita?
Yes, call me Nita.
Yes. So how are you doing, Nita?
I'm good, thank you.
Yes, good to know that. So, Nita, I understand that you want to know about the labor care guide. So, may I know what do you already know about the labor care guide?
Yes, actually, I don't know much about it. You know, the other day I
Mhm.
saw this labor care guide, and you know, my seniors were saying that this is a new one, and I want to fill, I was not able to fill it correctly. I was just able to fill the name. And, I have brought this one. I don't know about these sections, I don't know how to
Yeah.
fill them.
Yeah, don't worry, Rita. We are here to support you. Actually, we learned with our colleague and seniors, okay?
Mhm.
So we'll go through that today, and we'll actually previously there was part two. We have a format to record the progress of labor, and where maternal, fetal, and progress of labor were recorded in a graphical form. We call it partogram, but these days actually it has been replaced by labor care guide. So this labor. So are you aware of that previous partogram?
Yes, I know about that one.
Mhm. So, regarding this labor care guide, so I'll explain about that, and so and I'll also discuss about that what changes has been made during this. Okay.
Yes.
Okay. So, first of all, we know that what is labor care guide. Actually, labor care guide is very important because here it shows the graphical representation of monitoring of fetal condition, maternal condition, progress of labor, and what supportive care we give to patient, and what decision, like shared decision we made during the process. Okay. So this is very important because it can be a medical legal, it can be used as a medical legal point of view, because here we can show that we have monitored the patient well. Okay.
Mhm.
And it also maintain a continuity of care, because if anybody comes, like if we hand over the patient, so they will know that what treatment and how progress he did.
Mm.
Okay.
Yes.
Yes. So after that, in this new labor care, I'll explain about the what differences are there between the previous one and new one. So regarding the previous one, the supportive care was not there, and the shared decision making was not there. Okay,
Mhm.
and the progress of layer was charted in 1 centimeter per. The dilatation of cervix was not measured in 1 centimeter per hour. But here, the dilated here it is given as like at 4 centimeter, what should be the duration, 5 centimeter, what should be the duration. So these all are done by evidence-based measurement. Okay.
Yes. Okay.
So now, and also previously, it was at active labor starts from the 4 centimeter, and but in this labor care guide, they have decided to they kept at the point of 5 centimeter. Okay, and during in this labor care guide, there are two sections first stage of labor, and then second one. Can you see in this graph the right one? It is the second
Mhm.
stage of labor is also there.
Oh, yes, this one. Yeah.
Hello.
Yes, yes.
Previously the second stage was not there.
Yes.
Yes. Now coming to this new labor care guide, actually, so there are 7 sections in that. Okay.
Yes.
So in this first one is the demographic data. First of this is very important because we know that this is of which patient we are monitoring, like patient name, and when say patient came at what date. Okay, and then parity, says nulliparous or multiparous, and then when active labor began, so that so we'll monitor in that way. And after that, if membrane are ruptured or not, and at what time it ruptured, and how was the meconium in the upper section.
All right.
So, and some risk factors are also, if she
Yeah.
has, like she is diabetic, she is hypertensive, blood pressure, so there we also record it. Okay.
Exactly.
After that comes the section 2. Section 2 is like supportive care. Like supportive care means companion is there or not, pain relief, or how is the oral fluids is taking or not, and then posture. So companion is very important because it reduces the discomfort and reduces the stages of labor as well. Okay.
Yes.
The time duration of the stages of labor, and also pain relief is very important, and the patient should not be dehydrated, and posture should not be supine. So I'll come to that what are the alert and action column. First we'll go through the all the sections.
Yes.
So section third, you can see that it is the fetal condition are monitored, like baseline heart rate is there, if deceleration is there, amniotic fluid, if it is meconium stent, blood stent, then position, if it is posterior or transverse, then caput, 3+ caput is there, then it is alarming. And so also then just I want to tell you that these parameters, like I'm telling you, these are alert. So if these things are found, like if caput is 3 and molding is 3, then that means that it is alert. We circle it with a red line, red circle. Okay.
Yes.
And if it is not there, then it's good. Then in section 4, the mother's condition like blood pressure, pulse, then temperature, urine, these all are very important. Like if acetone and protein, what is there? So we know about the condition of mother. Then contractions, then labor monitoring. In labor monitoring, contractions are there, and then labor dilatation and the descent. Contractions, like how many contractions are there, and then duration of contractions. So previously it was the frequency of strength of contractions was also there. That is not there in this labor care guide. Okay, this is the new. They have removed from it. And then, so if normal contraction is 3 to 4, if less than 2 and less than 2 is alert line, more than 5, it is 5 and more than 5, it is alert line. Okay. Regarding that way, we see the parameter and we circle it if it is alert. Okay.
Yes.
So regarding the dilatation of cervix and descent, like if, as I told you that previously it was kept at 1 centimeter per hour, and then alert or Excel line was there. So here they have taken the evidence-based measurement, like they show that at 5 centimeter, patient can be at till 6 hours. Okay, like this.
Yes. Okay.
So we see that. So then descent also, and we I'll tell you that how to chart this one, but first we go through the section. Then like section 6, there is a medication. If we start oxytocin if needed, if IV fluid is given, then this is given, charted in that. And in section 7, this is also the shared decision making, because taking patient in consent is also very important. We should keep involved the patient in her care. So assessment would be charted here. Then what we make the plan, that should also be written over there. Okay. Then at last, who is charting this graph? So he will sign the initial, put the initial here. And
Yes.
then now coming to the how to chart it at this, yes, like I told you that, so here all the parameters are monitored hourly, but fetal condition and like fetal heart rate and the contractions and duration of contractions would be charted half an hourly. Okay.
Yes. Okay. Yes.
And then, like then coming to the first alert column, like if companion is not there, then every hour we monitored. In companion is not there, then we write it that it is no. No means it is alert. Okay. So like first hour, like if patient got admitted at 6 p.m., that 7 p.m. we are seeing that companion is not there, then it is alert. Then if present, then we write yes. Okay. Then it would not be alert. So then a pain relief, like if she's receiving pain relief or not, like any analgesia is given or not, then like that way we have to see all the alert thing, and if any alert thing is there, we have to put the circle. So
Yes.
if anybody look into that, then he will be aware that what is going on. Okay.
Right. And what about this 12 hours? So
Yeah, if it is 12, this is charted. Mostly it happens that in labor last for first stage of labor lasts for 12 hours. But if suppose it doesn't happen, normal duration is 8 to 18 hours. If this doesn't happen, that then we can take extra graph as well, and we can monitor chart on that paper as well. Okay.
right. Yes.
So
yes.
normal duration is 8 to 18 hours in first time mother, and then 5 to 12 hours in second time mother. And after that, we transfer this to whenever patient gets fully dilated, then we like in second stage of labor she comes, then we shift this chart to monitoring this chart to the second stage of labor. You are seeing this one, second stage?
Yes.
It is charted for 3 hours, because in primary gravitas, 3 hours we wait, and then all the parameters are like.
Exactly. Yes.
Yes. Okay. So
Time
any
is up.
other thing you want to know?
No, no, thank you.
Okay,
Very
I'll
good.
give you the reading material about that, and you okay. So
Mhm.
next time when you can come in the labor room, we'll do it together.
Fine. Okay.
And how was the session?
Very good. Very good.
Okay, thank you.
Yes, you have explained it very nicely. So,
But I got confused with like when should I compare with previous one or not, because I have not seen that questions like what all
because
yeah.
you compared, because you know that was the question asked by the junior in the exam. So, what is the difference between the
I think here also in first page I saw that. Yes.
okay, just you have to explain what is labor care guide, the aim
Okay.
and importance, and then you will
What are new columns only?
yes,
Okay,
and
that I
what
got
are the-
confused that yeah.
okay, what are the new columns? So yes, the second and seventh column, and alert column is a new, monitoring of second stage is new.
And second.
Both things are new. Yes, and explain what is deceleration.
Yes, the
Yes.
yeah.
So when you are
Yeah.
talking about the fetal section, so here
Yeah,
itself,
that time only.
yes, you can say, so do you know what is deceleration? Explain. Do you know what is K-pit? Explain. What is small? You can explain. Well done, otherwise.
Yes.
Good. Okay. So how you can involve your other colleagues? So for the pain relief, if patient is not having any pain
Yes.
relief, we can inform our anesthetist. Right? So if there is any concern, K-put is 3 plus, molding is 3 plus. If there is any alert, then we have to inform our consultant. So this is how you will get marks in communication with colleague also. So well done otherwise. Very good. Communication with colleagues, it's okay. Just involve your anesthetist and consultant, midwives, applied clinical knowledge, patient safety. Absolutely fine. Good. You have to know the alerts. So if I'll just explain first what is the labor care guide. So yes, just 1 or 2 lines is enough. It is graphical representation of the progress of labor, in which like there is important information about both fetal and maternal well-being, and also we can see the progress of labor, like cervical dilatation and also the descent of presenting part. So that descent of presenting part is the fifth of the head palpable. It is not related to the ischial spines. That was also confusion when this new labor care guide came. All right. And what about the aim and importance? So it helps in monitoring and documentation of both the maternal and fetal well-being and also the progress of labor. And it helps all the staff to offer supportive care to the mother, and helps to identify any labor complication. It prevents unnecessary interventions in labor, very important document to support the audit and quality improvement, and also a very important medico-legal document. So we are using it for all women in the labor, both low and high risk. High risk women may need additional monitoring and care. When we started, when cervical dilatation is 5 centimeter or more, and it is used at all levels of care in health facilities. Now, how to fill the section? So I have just taken one by one. All right. So section 1 is the patient identity and also the labor characteristics. So you will fill the full name of the patient, the parity, onset, labor onset, whether it is spontaneous or induced, then active labor diagnosis, what is the date? Membranes ruptured, if so, then what is the date and time? Any risk factors, like you told, if previous cesarean section, diabetes, hypertension, any medical comorbidity, stillbirth anemia, fine. Section 2, supportive care. This is a new one. So what is in the supportive care? We have to see whether she is having companion, pain relief, oral food, or posture. And then how we fill it. So if there is no companion, so and you can see an alert column. So if I will go back here, so you can tell to the junior that now we also have a alert column. This is also new. So all these columns are the alert column. So in every section, we will compare if there is any deviation from the normal. So if there is any deviation from the normal, so that is an alert for us. So here Companion, if no companion, we will write N and circle it with red. So this is alert. If she has companion, then yes. Pain relief, no pain relief, it is an alert. Posture, supine posture is an alert. It is in the alert column. So we have to encourage the patient to be mobile. Once she is mobile, it's okay. It is not an alert anymore. All right. Then how we are filling it every hourly. Like you said, we are filling it every hourly. Coming to the baby, this care of the baby section, section 3. So you can see here, this will be again the alert column. So fetal heart rate less than 110, more than 160 is alert. So here we have the jotted line. It means that we have to measure the fetal heart rate every 30 minutes. Decelerations measure every 30 minutes. Late deceleration is an alert, but if there is no deceleration early or variable, it is not an alert. Amniotic fluid, meconium 3+ is an alert, blood stain is alert. If it is clear meconium, we will write C. Fetal position, occipito-posterior, occipito-transverse is alert. If it is P, it is an alert, we will encircle it with red. Caput 3+ is an alert, molding 3+ is an alert. Okay, then coming to section 4, care of the woman. So again, we have to see the pulse, blood pressure, temperature, urine. So this is again all the alert column. Now how we measure, monitor the woman. So, this is done every 4 hourly. So 0 hour, 1, 2, 3, 4 hour. 0 hour, 1, 2, 3, 4 hour. This is also every 4 hourly. Like vaginal examination is also mainly done every 4 hourly if everything is going on well. Then labor progress, contractions per 10 minutes. So this is an alert, less than 2, more than 5. It is measured again every 30 minutes. Duration of contractions, less than 20, more than 60. So again, 30 minutes, every 30 minutes. Labor progress, we have to see the cervical dilatation. We will plot it as X. And here, now we will see that if patient is 5 centimeter dilated, and she can remain there for at least less than 6 hours. If up to 6 hours or more, it is an alert. So 6 centimeters, she can be allowed to be 6 centimeters for less than 5 hours. If 5 hours or more, it is an alert. Descent, it is the descent of the head. That is like the fifth of the head palpable. All right, so you can see the cervical dilatation is 5 centimeters. So 4/5 of head is palpable. So 5/5, 4/5, 3/5. Okay, so just remember, this is not the ischial spines. This is the descent of the head. 0/5, 1/5, 2/5. Okay. Coming to the medication. So yes, whatever medication is given, we have to write the name. If oxytocin is given, yes, it is given. So here it is N. It means no oxytocin has been given. Medicine, whatever medication is given, we have to write with the name and dose. IV fluids given or not. If yes, given, we will write Y, yes. If not given, no, N. Shared decision making, this is again a new column. So yes, assessment, assessment means we will see whether patient has any companion, does she need any pain relief, how is the progress of labor. Accordingly, we are going to make a plan whether she needs pain relief or companion. So we have to mention the plan. Initials, like you said, the person who is monitoring the woman, he or she will sign the initials. Okay, so if the patient's name is, my name is Shabana Ansari, so I will be signing SA. Okay, then, all right, now you also have to talk about other new things. So second stage column is also a new stage. And here it is only for 3 hours, like maximum patient will stay in the second stage for 3 hours. And here cervical dilatation, we will make it X. And if patient is pushing, then we will write P for the pushing. Then what else? What are the new things in this guideline? So we know the new section, supportive care, shared decision making, separates second stage monitoring, and also the alert columns. They are new. All right. And monitoring of the stage of labor is up to 12 hours. After 12 hours, there's no space in this labor care guide. So if the patient is still in the first stage, we have to start the new labor care guide for the first stage of labor. What is the difference between the old and the new? So this was the question asked by the candidate. I mean, by the role player. You will see the difference. First is before the partogram was started, when the cervical dilatation was 4 centimeter, now when it is 5 centimeter dilated. Now there are evidence-based time limits. It is not 1 centimeter per hour. There is no alert line and action line. There is only alert column, and the time limit is evidence-based now. There is a second stage monitoring. Then there is the supportive care. That is the labor companion, pain relief, fluid intake, posture, and everything. In uterine contractions, we are now monitoring only 2 things, duration and frequency. Now we don't monitor the strength. Then there is an alert column. So if there is any deviation from the normal, it can be highlighted. We are going to encircle it with red so that everyone will be alerted. Okay. Then if when you're talking about the fetal column, then at that same time, you're just going to explain what is deceleration. So early, variable, late decelerations, you will explain. We have done this in the CTG, so I will not repeat. Caput, keep it simple. In this, there is swelling of the newborn, and it occurs because of pressure on the baby's head as it passes through the birth canal, and there occurs accumulation of the fluids below the scalp. Most of the time, it will resolve spontaneously. There are different degrees of the caput. So 0 is no caput, +1 is a small, +2 is medium caput, +3 is a large one, and this will be an alert. Okay, then what about the molding? In this, there is overlapping of the fetal skull bones. So there are also degrees of molding. 0, there is no molding. 1+, skull bones will only be touching, and 2+, sutures and skull bones will be overlapping but reducible. 3+, they will be overlapping and not reducible. So 3+ is your alert. All right, so any questions? How was the session? How did it go? All right, and I hope you are able to fill the sections of labor care guide. I will give you the important articles and strategy. If you wish, I can arrange another session. All right, thank you. Have a nice day. All right, any questions?
Yes, doctor, please can you explain me again how to fill this cervicogram, cervical dilatation, and because before there is alert line and action line, but now what it is here written in this section, how to put this progress of labor.
Yes, yes. 1 minute. Where is my sharing? I think 1 moment. I think I pressed something. I cannot see the screen myself. 1 minute, 1 minute. Just a minute. I'll start the sharing again. Okay. So this one you're asking about the filling of the labor progress. Okay. So I will come to the enlarged one to explain you. Cervical dilatation plotting. So we are going to plot it with X. When we are going to start the labor care guide, when the cervical dilatation is 5 centimeter. That is why this is centimeters, 5 centimeters, 6 centimeter. So if patient is 5 centimeters, so she can remain in 5 centimeters even up to 6 hours, not more than 6 hours. Okay. So otherwise that will be an alert. Are you getting me? If
yes, but they write 6 is equal to 6 or more than 6 hours.
Ideally she should be less
than 6 hours. Okay.
Less than 6. If 6 or more, it is an alert. Likewise, if she is 6 centimeters dilated, she can be there up to less than 5 hours. 5 hours or more, alert. 7 centimeters, less than 3 hours. Up to 3 hours or more, alert. 8 centimeters, 2.5 hours. Okay. Less than 2.5 hours. If up to or more than 2.5 hours, alert. Likewise, 9 centimeters, less than 2 hours. and more than or equal to 2 hours, it is an alert. So when the patient is in 9 centimeters dilated, and we have to do the vaginal examination at least after 2 hours. We cannot now do the examination after 4 hours. So here the duration will be reduced when we are doing the examination. Normally it will be 4 hours examination only. All right. So like here 5 centimeters. So examination was done here 0 hour, 1, 2, 3, 4 hour. So after 4 hours, patient is 8 centimeters dilated. Now 8 centimeters. So at least by 2.5 hours, we are going to do the examination. So 0 hours, 1, 2. Suppose this one is 2.5 hours. So here she is fully dilated now. Still confusion or?
Oh, yes, okay, thank you.
All right, good. Suppose she was here 7 centimeters. So after 3 hours, we are going to examine. Suppose it was X plotted here, X here. Then this will be the 0 hour, 1, 2, 3. Again, we have to measure, do the examination. All right, and whenever we will do the this examination, we will also do the abdominal examination, assess the descent of the fetal head. All right, so this is not ischial spines. Some candidates said ischial spines. No, my dears, this is not ischial spines. This is the fifth of the head palpebral. Okay, fine. You just have to see everything and explain to the role player. So you just practice it and it will come spontaneously. Like the way Shweta has done it, it's really good. Explain all the sections. Okay, this, and then all the alert things. And whatever concerns the junior has, then you're going to explain that. Okay. So now I also need the feedback. How was the session?
Yes,
Very good.
it's very good.
Very good and in detail.
Okay.
Feedback we got.
Thank
Yes,
you.
Really very nice.
Thank you. Even I'm happy to have you all with me. Few are not here. I hope they will join next time. So Monday, Thursday we will meet, and I will share the stations. So it will be labor and delivery part 1. I will share the stations. Okay, keep practicing. All right, and I'll share the recording once it is processed. It takes little time, but I will upload it. Thank you and good night. Okay.
Thank you.
Okay.
Okay.
Bye. Thank you, listeners, also. Bye-bye.
Okay.